We are live and you can start.
A warm good morning to everyone across India. I assume that there are several people who are logged in early enough into our program. So we have a galaxy of speakers and chairpersons to deliberate on the proceedings today. Without much ado, let's start this program. Magna Code Endocrine Update 2021. Sorry, we could not do it in person this year. Next year, for sure, we'll have a in-person program. So over to Dr. Shanmugha, who will be the MC of the first few sessions. Dr. Shanmugha. Dr. Sundar, you're muted. Dr. Sundar, you're muted.
Yeah. Good morning, everyone. Thanks, everyone, for joining this meeting. And without wasting the time, we will go into the meeting. So to chair the first session, we have two eminent faculties. Dr. B. Sridhar is a consultant endocrinologist at Samraksha Diabetes, Thyroid and Endocrine Hospital at Warangal. And he has done his MD Internal Medicine from NIMS Hyderabad and BM Endocrinology from Osmania Medical College. And to join him is Professor Venkatesh, he is a cardiologist, senior interventional cardiologist at Apollo Hospital, Bengaluru. He has occupied in various positions in various societies. He was the past president, Cardiology Society of India, Karnataka, ex-vice president, Cardiology Society of India, Bengaluru chapter, and also he is an executive member in various society, and also he is an ex-expert panelist in the Lipid Association of India. So over to Dr. Sridhar sir for introducing the topic and introduce the first speaker.
Good morning, doctors across the country. This is a privilege to me to introduce Dr. Prem, who is endocrinologist at Salem. He did his MBBS from Jipmer Pondicherry between 1997 to 2003. And his internal medicine from PJ Chandigarh, 2004 to 2006, and DM endocrinology in PJ Chandigarh from 2009 to 12. It is my privilege to introduce him, Dr. Prem, to start his talk on role of inflammation in type 2 diabetes and relevance of hydroxychloroquine in therapy. And I request Dr. Prem to start his talk. Thank you.
Thank you, Dr. Sridhar, good friend, for introducing me and the topic. And I sincerely thank the organizers of Magna Code, Dr. Santosh, Dr. Anantharaman, Dr. Sundar for the kind invitation. And so, dear friends, for the next 15 to 20 minutes, we look at the recent advances that has happened in the field of diabetes and inflammation. As I hope the slides are visible, right? Okay. So as our understanding on diabetes has increased, now we know that there are not just 8 players in the pathophysiology of diabetes. Now the list has increased to 11. What is now called as the EGS 11. And if you look at the 3 new additions to the pathophysiology of diabetes, these are increased glucose absorption from the gut, which actually is targeted by alpha glucosidase inhibitor. There is altered gut microbiome, and this has been recently added and well appreciated too. And the last one to be added is the immune dysregulation inflammation, which will be the topic of discussion for today. So this put together forms the egregious 11 in the onset and progression of diabetes and its complications. So let's see whether this topic of inflammation diabetes is a hype or hope for the future. So if you look back in the history, and the relevance of anti-inflammatory agents in diabetes was well appreciated in the early 20th century when salicylic, the prodrug for salicylic acid and further congeners, was found to reduce glucosuria. And initially, they did not know the reason why there is reduction in glucosuria. Later on, it was found to be due to inhibition of serine kappa B, which actually reduces the TNF alpha generation by inhibiting NF kappa B. And later on, people also found that salicylate reduces the insulin degradation. And it also acts by post-receptor mechanism and reduces glucosuria. In fact, there are 20 studies on this particular molecule, and there was a meta-analysis of 8 studies. And in this, they showed a significant reduction in the glycemia, But in addition to that, there was a increase in the LDL level, slight increase in LDL level, and also increase in the albumin-creatine ratio. And that was the reason why they were not continued and further research didn't happen with this particular molecule, though it's a cheap and has fewer side effects. And later on, there were a lot of preclinical studies, and this particular author, in his animal study, found there is increased expression of TNF alpha in the adipose tissue. And when he gave a neutralizing monoclonal antibody, there was increased adipocyte secretion and reduced inflammatory markers, and there was improved insulin sensitivity in the animal models of type 2 diabetes. And that's how this concept of inflammation in diabetes evolved over time. And we all are aware about the selective autoimmunity to beta cells in the islets in patients with type 1 diabetes. And if you look at the inflammatory mediators, which leads to apoptosis of beta cell, these are TNF alpha, RAJ, interleukin 1 beta, and interferon gamma. So these are the various inflammatory mediators which activate, which increases the oxidative stress, endoplasmic reticulum stress, JAK-STAT pathway, and causes a apoptosis of beta cells, which is selectively directed to the beta cells in the islets. And a lot of studies had happened initially with the T cells with the monoclonal anti-CD28, and later on they targeted B cells like rituximab. And what they found was there was a reduction in the progressive loss of C-peptide reserve when these monoclonal antibodies was used as early as 1 year after diagnosis of type 1 diabetes. Less than 5% of the people achieved insulin independence. So this particular molecule was promising, but did not give a long-term result. But still, research is ongoing. But still, I think it holds a hope for the future in managing type 1 diabetes, which is irreversible with respect to insulin in initiation and use. Now coming on to type 2 diabetes, what you see here is the electron microscopic slide of the beta cells. What you see in the left side is the controls, where you see that CD68 positive cells are literally absent. If you look at in the right side of the photograph where type 2 diabetes beta cells has been projected, what you see is the insulin producing cells are relatively sparse, and there is increased infiltration by the antibody positive immune cells. And there is also amyloid deposits there. And there is the pathogenesis, the pathophysiology like amyloid is due to the inflammatory damage, and it's a strong stimulator for TNF alpha. And that's why the drug called pramlintide was initially used, which prevents the amyloid deposits. This is the electron photomicrography of the immune cytochemistry of beta cells again. What you can see here, there are a lot of immune cells that are interspersed in among these various endocrine cells in the islets. And these beta cells selectively express chemokines and cytokine receptors in them. So this in type 2 diabetes. So there is a strong association between these immune receptors and the beta cells and their association with progressive beta loss. So well-studied molecule among all the inflammatory mediator chemokines and cytokine is interleukin 1 beta. And it's well established that beta cells has IL-1 beta receptors in them. And there is a constant stimulation in type 2 diabetes with IL-1 beta, and they increase the oxidative stress and endoplasmic reticulum stress, and they activate TNF alpha and further leads to generation of other inflammatory cytokines. And this may be one of the reasons why there is progressive beta cells in patients with diabetes. So let's see what is the source of these immune mediators in patients with type 2 diabetes. If you look at all the studies, then they all point to a common source, the adipose tissue. What you see here is a histopathology slide of an adipose tissue. The large cells with clear space are the adipocytes. So adipose tissue is not only comprised of adipocytes, but also pre-adipocytes. You can see macrophages infiltrating the adipose tissue, endothelial cells, fibroblasts, and leukocytes. So it's a huge tissue with not just adipocytes, but various other cells, but also inflammatory cells, as you can see here. And initially in the early 1980s, we thought adipose tissues are meant for storing the excess nutrients, and they insulate the internal organs. Later on in 1990s, we know that it secretes hormones like leptin and adiponectin, and is useful in the insulin sensitivity. And now we know that adipose tissue is the largest endocrine in our body, and it secretes more than 600 adipokines. And these are the various substances which the adipose tissue secrete. And internet connection. So I think I'm audible. Okay. What you see in the right side is the various cytokines and chemokines that are secreted in the adipose tissue. These are the TNF-alpha, MCP1, interleukin-1, and the prostaglandins and other things. So what you can see in this particular slide is the adipose tissue has got a control. It regulates various processes in the brain, in the endothelial cells, in the liver, in the pancreas, in the muscles, and also in the gut. So adipose tissue, by secreting various adipokines and chemokines, has control over the metabolic function of these various organs which we have discussed just now. So what determines that your adipose tissue is good or bad? Large adipocytes store a lot of free fatty acids in them, and because of the sheer size, it compromises the vascularity. So small adipocytes are insulin sensitive, large adipocytes are insulin resistant. So whenever there is increased nutrient storage in the adipose tissue, which are large, there is compromise of the blood circulation to the adipose tissue. This leads to expression of macrocyte chemoattractant protein MCP1 and also secretion of hypoxemia inducible factor 1. And this leads to inflammatory infiltrate in the adipose tissue, and various other inflammatory cytokine pathways are triggered. And this inflammatory pathway, the markers which are secreted from adipose tissue, they spill over into the systemic circulation in the liver, causing steatosis in the muscle, causing inflammation, and also in the kidneys, and also vessels, leading to endothelial inflammation. So increased free fatty acids, increased glucose, and also endothelin, lipopolysaccharide, they act on toll-like receptor, and they lead to increased inflammatory mediator generation by activating TNF-alpha. This is the, in nutshell, what happens in diabetes and inflammation. And it's also found that the microbiome in obese patients is different, and their gut is leaky. So all the lipopolysaccharides secreted, the endotoxin secreted from the gram-negative bacilli, they enter the systemic circulation in a huge number, and they again stimulate this toll-like receptor, TLR4, and lead to further generation of inflammatory media. And these inflammatory mediators also damage the beta cells. So inflammation not only reduces the beta cell number, but also increases insulin resistance. By oxidative state at the muscle and the liver, it increases the insulin resistance by post-receptor mechanism. And this particular phenomenon is recently coined as, the concept is called as meta-inflammation. Adipocyte producing inflammatory mediators which spill over into the muscle and liver, causing increased insulin resistance, is called as meta-inflammation. And that's why this particular topic is relevant for today. So how to measure inflammatory mediators? One can measure IL-6, TNF-alpha, but these all are done in the lab. Of course, with post-COVID, we are measuring IL-6 level. The one easy marker what we can do is CRP and HSCRP. In obese patient, OAC, if you see, HSCRP will be elevated. Newly diagnosed diabetes, it will be elevated. So these are the people who have got a huge inflammatory load, and they have got inflammation in many of the tissues, what we have mentioned recently. So one particular marker is HSCRP, and this may be an indicator for this particular patients will respond to anti-inflammatory agents. So I think now you will understand that type 2 diabetes is a state of low-grade inflammatory disorder at the beta cells and also in the other target organs. Not only that, inflammation also drives the diabetes complication by increasing the RAGE pathway, but further worsening the nephropathy, neuropathy, and retinopathy. Everywhere the oxidative stress happens. And how to deal with this inflammation? Well, just modification of your diet can reduce the inflammation in diabetes. People have found consuming less than 30% of saturated fat and less than 30% energy contributed by fat reduces the free fatty acid level in the circulation and reduces the inflammation in the liver and the muscle. That is one way. And second thing is reducing the high index glycemic index food and increasing the protein in the diet has also found to be useful in reducing the inflammation. So that's the various studies, preclinical and clinical trials that has been projected here. All of them show that the markers like IL-1, IL-6, and the HSCRP reduce by just altering diet. And similarly, consistent exercise on a regular basis, not a strenuous exercise once a while, actually reduces the TLR4 expression and increases the cortisol, which again causes immunosuppression, and it also reduces the vagal tone and various other features, and it also influences the gut microbiome. So regular physical activity also reduces the systemic inflammation, reduces HSCRP. And activities like yoga also reduces HSCRP. And the existing anti-diabetic do have some anti-inflammatory role. Metformin has been well studied, but it's not that efficacious in reducing inflammatory markers. The sulfonylureas, especially glycoside, have been found to reduce the oxidative stress and improve the insulin sensitivity at the level of the muscle. The well-studied drug is pioglitazone. By PPR gamma activation, it reduces MCP1 synthesis and reduces the inflammatory load. And similarly, DP4 inhibitors, by its receptor presence in various organs, causes an immunomodulatory role, and it also reduces TNF alpha expression. Insulin directly inhibits the NF kappa B, and it directly reduces the lipolysis and reduces the free fatty acid generation, thereby reducing inflammation in the liver and in the muscle. The well-studied molecule and the most promising molecule, one of promising molecules, GLP-1 receptor agonist. And this particular molecule, when used in, beta cell in the preclinical studies in the experimental lab, it reduces NF-kappa B expression. And it's also found in obese patients with diabetes. When GLP-1 receptor agonists are used, there is reduction in the hsCRP, IL-1 and IL-6 level, systemic immune marker, and also fibrinogen and other markers were reduced when GLP-1 receptor agonists are used. That may be another reason why they have beneficial cardiac and renal outcome. Regarding SGLT2 inhibitors, by their hemodynamic alteration and reducing the glucosuria, they can improve insulin resistance at the level of the muscle and also improve insulin sensitivity at the level of the beta cells. And people have found anti-inflammatory action of SGLT2 inhibitors at the level of the kidneys. This has been proven beyond doubt in very many preclinical studies. So these drugs hold promise. They not only reduce the glucose but also reduce the inflammatory complications at the target organs. So anti-inflammatory agents have an important role with the diabetes and its complication in the future. It opens another window of opportunity to target inflammation. So these are the various potential target one can think about. We have got salicylate, we already discussed. We can have a etanercept and other monoclonal antibodies against various markers. But again, they are costly, and there are studies which were done with this molecule, and they are smaller studies. We don't have much data. One good data what we have is with canakinumab, which is an interleukin-1 beta receptor antagonist. And there was a CANTOS trial that was published in NEJM few years back. Basically, in CAD patient with high CRP, this particular molecule was used. And what they found was there was a 30% reduction in the hsCRP, and there was a 15% reduction in the 3-point MACE. Not only that, many of the patients had either pre-diabetes or diabetes. What they found was those who had pre-diabetes and follow-up, they have reduced progression to diabetes. And this is a proof of concept to say that anti-inflammatory agents prevent diabetes, progression of pre-diabetes to diabetes. And there was a significant reduction in HbA1c that was shown in this CANTOS trial. And these are the various studies which targeted these markers, and many of them are smaller studies done for a shorter period of time, and they showed a reduction in the inflammatory markers in type 2 diabetes and a slight reduction in the HbA1c, but not huge enough. We don't have any strong evidence that to recommend its use in patients with type 2 diabetes. But what is well known is hydroxychloroquine, which we'll be discussing in the next few slides. This particular molecule has been used for many decades, and we know that it reduces interleukin-1, interleukin-6, TNF alpha, it reduces CRP level, prostaglandin synthesis, and it also reduces leukocyte migration. And it has been safe in the continued use in rheumatoid arthritis, in various skin disorders, and prophylaxis. And people have found in preclinical studies this particular molecule reduces the insulin degradation. It improves the insulin sensitivity and it prolongs the half-life of insulin in preclinical studies. And many authors as early as 1990s have found its beneficial role in patients with diabetes, its efficacy in reducing the HbA1c and the fasting and postprandial glucose. And but these were all smaller studies, but there were no any properly conducted randomized controlled trial to advocate its use in management of routine diabetes care. In 2014, we had this first phase 3 trial that was submitted to DCGIA. And in this particular study, on top of metformin and sulfonylureas, one group was started on hydroxychloroquine, the other group was started on pioglitazone, and they continued the study for 24 weeks. At the end of 12 weeks, there was a 0.856% reduction in the HbA1c, and at the end of 24 weeks, there was a 0.87% reduction in HbA1c. And this HbA1c reduction was comparable to that what was achieved with pioglitazone. And this led to the approval of this particular molecule by DCGI in our country as an adjunct agent for diet and exercise on top of metformin and sulfonylurea in patients with type 2 diabetes. Since then, various studies have been published and presented in various conferences. One such study is this drug study which compared tenligliptin with hydroxychloroquine. And in this trial, which was added to metformin, what I found was more number of patients who were exposed to hydroxychloroquine achieved a A1C less than 7 compared to those who were receiving tenligliptin. And this particular study looked into the who are the right patients for this particular molecule, hydroxychloroquine. This study looked at people with insulin resistance, those people who are on multiple OHAs and receiving insulin more than 30 units per day, still having poor glycemic control. A baseline A1C of 8.56 was taken. And when it was compared with placebo and hydroxychloroquine group, what they achieved was a further reduction, the significant reduction in HbA1c, and there was a further reduction in the insulin requirement. And they did a sub-analysis to find out who are the people who responded well. And what they found was those people who had a elevated HSCRP were the people who had a improvement in the insulin sensitivity, the reduction in the significant reduction in the HbA1c, and also the reduction in the insulin level. So this may be one segment of the people whom actually you should concentrate and think about using this particular molecule. And you all know about the long-term use of hydroxychloroquine and the increased incidence of retinal hyperpigmentation. And this actual risk increases when the duration of exposure is more than 5 years. And that's why the Ophthalmology Association advised regular screening after 5 years of initiation of this particular drug with an ophthalmologist to look for the pigmentation in the retina. However, the incidence is lesser compared to the usual expectations. And regarding its CV safety and kidney safety, we have this particular meta-analysis which was done with which was studied regarding the onset and new CV events in patients with rheumatoid arthritis who were exposed to hydroxychloroquine. And what you see is there was a 72% reduction in the onset and of new CV events in those who were exposed to hydroxychloroquine compared to those who were not receiving. So this may be one reassuring data to take that this particular drug, by reducing the inflammation, can reduce CV events. However, we don't have any CV outcome trial. But there are small trials which are ongoing. And this particular study from UK, which will be looking into the CV outcome when HCK is used. And this will be a placebo-controlled trial. And this is a small study which will be done in patients with CKD to look at the renal safety. In years to come, will have the data regarding the safety in CVD patient and also CKD patients. So what's new? You all know about my last slide. You all know about the COVID and diabetes, right? And we have seen a lot of new onset diabetes happening. And this is the article published in Lancet. And even the IDF have started a new website to have a registry on new onset diabetes after COVID. So there is increased type 2 diabetes after COVID and also new onset of type 2 diabetes after COVID. And it's a great challenge to manage diabetes during COVID. And the reason being the cytokine storm. The cytokine definitely worsen the insulin resistance. So people have advocated many drugs for it, and many studies are coming now, and also reassuring. Existing drugs can overcome the inflammatory storm in cytokine, diabetes, and inflammation. So with this, I end my talk and will conclude that there are many agents to target various pathophysiological targets in diabetes. And inflammation is one such area which should be concentrated, and many studies are ongoing. We need much larger studies to advocate its use in larger group of people. So I think anti-inflammatory agents and drugs which target inflammation has a hope for future for diabetes and also its complications. Thank you.
Yeah. Thank you, Dr. Prem. It's been a very extensive and great lecture. You have spoken very extensively. It's really, at this time, we have increased our knowledge about this hydroxychloroquine and other anti-inflammatory drugs. So it's been really nice that you gave a very, very extensive lecture without leaving anything. That's great of you. Yeah, I think, yeah.
Correct.
Thank
Dr.
you.
Prem Kumar, I think, should be congratulated on his excellent talk. He has covered this topic in a very big way and very exhaustively at that. And just to probably summarize what he says, I think many of the studies have indicated that chloroquine as well as hydroxychloroquine use is definitely associated with lower glucose levels and also with higher insulin levels. And this could be probably because of increased rate of secretion of insulin and at the same time an inhibition of degradation of insulin as well. And the hydroxychloroquine probably improves the beta cell function. And I think the focus on beta cells and inflammation was brought out very well by Dr. Prem Kumar. Now, we all know about the anti-inflammatory effects of hydroxychloroquine, and they have been used in rheumatoid arthritis, systemic lupus erythematosus, and we have this thing called as immunomodulatory effect. But whether this immunomodulatory effect holds good in the presence of type 2 diabetes mellitus is a point of contention. Secondly, when we are trying to use hydroxychloroquine, we should probably be looking at the beneficial effects with respect to cardiovascular outcomes, as you showed and published very well in American Heart Journal. But at the same time, I would draw attention to a few more effects of hydroxychloroquine, like retinal toxicity, cardiotoxicity, and its harmful use in patients in whom we have chronic kidney disease, because hydroxychloroquine is a drug which is also to some extent eliminated by the urine in the kidneys through kidney elimination, and accumulation of this drug can happen. And when you use hydroxychloroquine along with certain other agents, like especially azithromycin and these macrolide antibiotics and some antivirals and antifungals, there can be a prolongation of the QT interval, and this can lead to arrhythmia. So these are certain areas where we have to be a little careful when you try to use hydroxychloroquine. And to the best of my knowledge, the guidelines have still not recommended use of hydroxychloroquine routinely as either a glucose control strategy or to preserve beta cell function in diabetes. Am I right on that? Do you agree on that, Dr. Prem Kumar?
RSDA has acknowledged the role of hydroxychloroquine in treatment of diabetes, and it is the only society which has recommended its use. And as a third is when diabetes is not controlled with two agents, but what I can my personal experience, sir, in those with obesity, like new onset of diabetes, people with high HSCRP, they should good respond. With diabetes, periarthritic shoulder, and where this particular molecule, when we initiate for periarthritic shoulder, that's a good control of diabetes. But there are some people who do not respond at all. So we need further data to know who will be the right candidate. As you rightly told, concomitant use of azithromycin prolonged QTC is a real thing, and we have seen during the COVID times a lot of well-known personalities succumbing into sudden death. So underlying cardiac toxicity is a real thing. So I think we should choose patient accordingly. And I think when diabetes with periarthritis is there, you should use this particular drug when contraindications are not there and they get a benefit. And yes.
Perfectly said. Perfectly said. Especially this combination of using azithromycin with hydroxychloroquine has always been a point of contention even in COVID times, because in COVID, this was one of the protocols which was advocated initially, where you needed to give both azithromycin along with hydroxychloroquine, but that somehow did not, find its way into any of the established protocols. But I think your content of your presentation was very lucid, excellent, and the message was wonderfully conveyed. Thank you so much, Dr. Prem Kumar. So nice of you. Thank you. So can we move on to the next section then?
Oh, yes, sir. You can introduce the next speaker, sir.
Yes, and today we have another eminent speaker, Dr. R.N. Mehrotra. He is a DM from SGPGI Lucknow. Present position, he is a senior consultant at Apollo Jubilee Hills, Hyderabad. He's published number of papers on diabetes, growth, and osteoporosis, and he's got an active interest in clinical research with respect to diabetes and osteoporosis. And today he'll be telling us about the pleiotropic effects of SGLT2 inhibitors. And this is something which we are all looking forward to, because SGLT2 inhibitors have been criticized for one reason. The molecules have got a lot of clinical trials behind them, but nobody seems to know the mechanism of action properly. But now, the criticism is that first we should know the mechanism of action, and then it should be used for clinical use. But exactly opposite has happened with respect to SGLT2 inhibitors. We have a lot of clinical data, but we do not know the molecular mechanisms behind it. So in this context, of course, now a lot of research, a lot of work is being done. We now seem to know the starvation theory and the myocardial kinetics, and we also know about how the myocardium gets into a hibernating state, as if mimicking the starvation, and it switches from aerobic metabolism to anaerobic metabolism. And with all this, we all know that it plays a very important and crucial role in terms of preservation of the myocardium, especially with respect to its reduction in cardiovascular death and admission for repeat heart hospitalization. So with this short introduction, I will hand over to Dr. Mehrotra for taking the talk forwards. Thank you.
Good morning, everybody. Thank you, Chairperson, for your kind words.
Thank you.
I would definitely agree with Professor Venkatesh about the SGLT inhibitors. We all have been using it, and I think practically more than 6 years now. We have been using it in clinical practice, and we are still learning about the mechanisms, how does it cause benefits to us. So when Santosh talked to me about this topic, I was a little happy because we get some time to read about it. Normally, we use pre-made slides, but this was a time, an opportunity to make the slides on our own and then see. So today, talking about the pleiotropic benefits of SGLT2 inhibitors. Now, if you look at the mechanism of action, that's been well studied and well established. They basically, we know that the glucose is filtered from the glomeruli and is absorbed through the SGLT2 receptors or transporters in the proximal tubules, and the remaining part is reabsorbed through the SGLT1 in the distal tubules. And that leads to minimal glucose excretion in the normal person. In a person using the SGLT2 inhibitors, the reabsorption to the proximal tubule is blocked, and you find that there's an increased glucose excretion with the loss of sodium associated with it. Now, if you look at the side flow, with below the threshold, the renal threshold, all the glucose which is filtered is basically reabsorbed, and that basically comes to something around 180. In diabetes, the problem is that even though the threshold is basically moved to the right, and that means the glucose being absorbed even at the higher stages like 200, 240, you may not find glucose still in the urine. So SGLT2 basically inhibitors works in a good way to block that reabsorption of glucose, and you find that with the more excretion of glucose, the blood level glucose will start to come down, and there will be better glycemic control or glycemic effect even without the beta cell being taxed about it. For the initial data from 2014 studies of the registration studies of CANA, DAPA, and EMPA, you can find that reduction of A1C was tuned around 1 to 1.2, depending upon where it was used. Reduction of blood pressure was around 4 to 3 millimeters of systolic blood pressure, and weight reduction was around 3 to 4 kgs. So practically, this was the main effect that we had seen when the drug was launched in 2014. And then come all the severe outcome trials came, and that's really changed the paradigm. How do we change diabetes now? I'll show you a summary of the effects of the SGLT inhibitors on various organs. We know that it lowers the blood glucose, it lowers the HbA1cs, it causes the lower BP to come down, it lowers the blood pressure, has an effect on the HDL excretion, increased levels there. There's some effect on the LDL, but that is not really necessary, but the ratio becomes the same. They have a good effect on the urine albumin excretion. They reduce the uric acid. They increase the hematocrit. This was the basic data which we had in something around 2015-16. We know that it can lead to more genital fungal infection. It can lead to more UTIs or glycemic decays. Fractures is still, data is still there, but malignant tumors and the lower limb amputation, I think the box warning is out. They basically, because of mechanism of action, they can cause hypotension and dehydration if they coupled with the long amount of diuretics. what is the first effect, the weight loss? We know that basically it can cause an average weight loss of 2 to 4 kg. This has been seen in all the studies for all the molecules, either as a monotherapy or in combination with the anti-diabetic agents. It's a kind of sustained weight loss. We have studied up to 4 years, which have shown there's a weight loss is there. The mechanisms are still being studied, but one of the mechanisms basically as obvious is the glucose loss leading to loss of calories, leading to the decrease in the insulin-glucose ratio, which will further mobilize the fat from the peripheral tissues. There's some effect on the AMPK pathways and change in the mitochondrial function. There's a change of the polarization of macrophages M1 to M2. M1 basically are more for the inflammatory, M2 are more for protective. Browning of the adipose tissue, leptin inhibition, and leptin is increased. Now, if you look at this trial of 2 years of dapagliflozin, patients who were uncontrolled metformin were randomized either to DAPA or to placebo, I can see that there was a sustained weight loss of around 4.5 kg over a period of 2 years. There was a reduction in the waist circumference. Then the outcome basically is this, the patient losing the muscle mass or the fat mass. Initially, the weight loss basically is because of the fluid loss that is there. But then we see that predominantly the weight loss is basically coming from the fat mass, not from the muscle mass. This was further studied in the protocol from Japan, where they looked at the muscle mass in type 2 diabetes patients. They looked at the patients who were uncontrolled on the non-adjuvant drugs. They were randomized either to an SGLT2 or other drugs. There was a soft lean mass, and you can see that the soft lean mass is not being changed. The skeletal muscle mass is not changed. They looked at the Schwartz index also. That was not being changed. Now, if you look at this table, it shows that the patient on SGLT2 what was losing body weight. They lost their waist circumference. They lost total fat mass. Body fat percentage came down. But the soft lean mass was preserved. The skeletal mass was preserved, and the Schwartz muscle mass index was preserved. It's got reassuring because sometimes a very common complaint of patient on SGLT2 is that we are becoming more weak. Our relatives are telling that we are becoming weak. So you can reassure them they're becoming healthily weak because they are losing the fat but not the muscles. And the muscles can be maintained by doing a good amount of exercise. That will further enhance their muscle sensitivity. Next effect was basically seen on the blood pressure, and we have seen this across all the trials, and basically it's more like a class effect. This slide shows the effect on systolic blood pressure of DAPA is around 10 and diastolic is around 4.4 and diastolic is around 2.1. The mechanism, if you look at, if initially basically the diuresis and natriuresis, there has been a postulation of decrease in weight, but the further studies have shown not to be due to the weight, it is independent of the weight loss. The most important path which is coming out of the inhibition of sympathetic nervous system. We know that whenever we use diuretics, there is a loss of plasma volume, and with that we have the compensatory tachycardia. But here, even with the loss of the volume, we do not get compensatory tachycardia. So somehow the sympathetic nervous system is inhibited, which has a good effect on the blood pressure. They have been shown to have the beneficial effect on endothelial dysfunction or arterial stiffness, again, which is been shown in many studies. A path which is being investigated now in great detail is the presence of activation of ACE2 enzyme, which will lead to more generation of angiotensin 1:7. Now, this is a path for the fragment which will lead to more vasodilatation. Then there's the effect of the ACE2 inhibitor on erythropoietin, leading to better hemoglobin, and which will further lead to decreased arterial stiffness. This is a meta-analysis published around in 2017, which looked at the ambulatory blood pressure and effect on the ACE inhibitors, and basically they looked at all the trials from EMPA, CANA, and DAPA, and they found that the systolic blood pressure comes down, the daytime comes down by 3.76, and the night time is coming down by 2 millimeters, and this was independent of weight loss. So this basically is it could be a mechanism, but this is independent of weight loss. As I said, the sympathetic inhibition is becoming very important through this is being projected. And we know that basically it may play a very important role in the cardiovascular outcomes. There is a crosstalk between the SGLT2 and sympathetic nervous system, and that is being the further mechanisms are still being looked at. But this crosstalk basically is a very important pathway which could tell us how the blood pressure comes down and how the cardiovascular outcome is benefited. This was another mechanism that they have said. We know that the SGLT inhibitors will cause natriuresis. The increased sodium content in the cerebrospinal fluid has been known to stimulate the OVLT neurons, which would basically lead to more CNS peripheral system activation. This would be inhibited in the case you have loss of sodium in the urine. That pathway is inhibited. Moreover, we know that they decrease the blood glucose, they decrease the insulin resistance, they correct the anemia. Again, they all have a very important effect on the activation of carotid bodies, and the sympathetic nervous system will basically will be inhibited. As we were looking at the inflammation in the last lecture, here if we look at the inflammatory effect of the empagliflozin in the patient of type 2 diabetes, this protocol basically looked at the HOMA insulin resistance. Basically you can see that it comes down with the use of SGLT2. HSRP also comes down with the use of SGLT2. There's a very interesting article. They looked at the remnant of lipoprotein particles of the cholesterol, and also this decreases. And we know that importance of remnant particles and the process of atherosclerosis. Now, this is a very important pathway that has been looked at in the NLRP3 inflammasome. Now, basically, if you look at this inflammasome, it basically has an effect on the macrophages. It modulates the release of IL-6. This is increased in the presence of hyperinsulinemia. High glucose is basically a stimulator for this inflammasome, into more IL-6. Now, if you look at the effect of the SGLT2 inhibitors on that, it shows that here, the more glucose, more insulin leads to activation of NLRP3, leading to more IL-6. And if you have using the SGLT2 inhibitors, the glucose and insulin comes down. With that, we have the increased levels of beta-hydroxybutyrate, which are basically inhibiting the activity of NLRP3, and which will further then decrease the expression of IL-6 in the macrophages, and which will have a beneficial effect on the atherosclerosis. This was the protocol which looked at the use of this SGLT2 inhibitor for 30 days. And the patients were randomized to 2 parts, sulfonylureas and SGLT2 inhibitors. You can see that the glycated, not the HbA1c, but the glycated albumin does show a decline with the use of SGLT2 inhibitors, quite similar to sulfonylureas. But if you look at the fasting serum beta-hydroxybutyrate, which the ketone bodies are going up with the use of SGLT2. The uric acid is coming down with the use of SGLT2 inhibitors. The fasting serum insulin is coming down. The fasting serum fatty acids are going up with the this SGLT2 inhibitor. HOMA insulin resistance come down. The beta cell function seems to be improved. Now, if you look at the expression of TNF alpha and the IL-6 in the inflammasomes, you find that they are significantly decreased with the use of SGLT2, not so decreased with the sulfonylureas. This could be a very important pathway for the mechanism which we are looking for. Then come looking at the endothelial dysfunction. This was basically a protocol which looked at the logarithmic transformation of reactive hyperemia index, a surrogate marker of endothelial dysfunction. You can see that improving is with the use of dapagliflozin. You can see that the patient on the dapagliflozin, 75% showed an improvement, versus the patients who were on non-SGLT2, only 15% showed an improvement in the parameters of endothelial dysfunction. This protocol also looked at the association with the loss of the decrease in the body mass index. You can see that basically the BMI comes down with the use of SGLT2, body weight comes down, waist circumference comes down, total fat mass comes down, abdominal visceral fat is coming down, and the fat area in the abdominal also is coming down. Basically, this seems to go well with the loss of the body weight and fat mass. We are having an improvement in the endothelial dysfunction in the peripheral arteries. Now, as a chairperson said, we are still looking at the mechanism of cardiovascular benefit. Here, basically, some of the benefits have been enumerated. We know that the effect on blood pressure, diuresis and natriuresis is already there. Then improving the cardiac energy metabolism. There's a lot of new literature coming on that, and preventing the inflammation, weight loss is there. Improving the blood glucose control, inhibition of the sympathetic nervous system pathway. Looking at the cardiac remodeling and looking at the preventing of the ischemic peripheral reperfusion injuries. The cardiac sodium hydrogen transporter is a very important path which has been looked at. It reduces the hyperuricemia. It improves the increases the lysosomal degradation of the autophagus, decreases the epicardial fat mass, improves the erythropoietin, and decreases oxidative stress. They all basically play some part of the role. Exactly, we cannot say that this is the only pathway which helped the SGLT2 to decrease the CV outcome trial. Now, this was basically which showed us if you look at the heart of an untreated diabetic, there is an abnormal metabolism. It is not energy efficient. They decrease, they generate less amount of ATP, and the metabolism is basically more towards the glycolysis or the glucose, which is not very efficient. If you look at the initial theory which came in, they said that the ketone body would be altering as an alternative fuel. But that has not been very, very shown now. Basically, what this shows, if you are using the SGLT inhibitors, we do see a rise of beta-hydroxybutyrate, now which, if the levels of goes at the cardiomyocytes, they have a very beneficial effect on the inhibition of the hypertrophic transcription gene. So that part is blocked. Moreover, once you block they have seen the blockage of even the keto acid oxidation, which leads to less amount of acetyl CoA being generated through keto acid oxidation, which leads to more energy efficient use of pyruvate into the TCA cycle, and it blocks the hyperacetylation of the mitochondrial enzymes, leading to more energy efficient generation from the mitochondria. Another important pathway is the sodium hydrogen exchanger. We know that the hypoglycemia basically stimulates the sodium hydrogen exchanger. With that, you kind of find an accumulation of sodium and the calcium in the cytoplasm of the cardiomyocytes, but it is depleted into the this cardiomyocytes mitochondria. So once you use the SGLT inhibitors, the blood glucose has to come down. It basically directly inhibits the sodium hydrogen exchanger, leading to decrease in the cytoplasmic sodium and calcium, and improving the calcium of the mitochondria, which leads to more muscle activity, or the more efficient activity and generation is there in the myocytes. The pathway, the increased level of erythropoietin, they play a very, very important role, which may be because of the decreased renal blood flow, because of the afferent arterial vasoconstriction, or generation of beta-hydroxybutyrate, which may be a direct stimulator for increased erythropoietin, which has basically an effect on the erythropoiesis and erythrogenesis, and which lead to increased oxygen delivery to the cardiac myocytes. It has an effect on the cardiac circulating progenitor cells, more towards the cardiac remodeling, and decrease of the inflammatory mediators in the full system. We have seen this beneficial effect in RAPA heart failure trial. This was basically a trial of more than 4,700 patients of diabetes, without diabetes and with diagnosis of heart failure, and they were randomized to DAPA or a placebo on a maximum. They were already on baseline use of ARB and diuretics, and you can see that we looked at the primary composite endpoint of the cardiovascular death, heart failure, and urgent heart failure visit. There was a severe reduction of the cardiovascular primary composite endpoint was seen. This was basically sustained even the specified subgroup analysis, whether the patient was elderly or male or female or any kind of different race, had basically diabetes or no diabetes, had a pro-BNP elevated or no elevated. He did get the benefit of decrease in the composite endpoints. Look at the nutshell. If you look at the direct effects of the cardiac, the SGLT2 on the cardiac myocyte was through the NLRP inflammasomes, through the sodium hydrogen exchanger, through the stimulation of that calmodulin dependent protein kinase, and change in the liposomal activation to autophagy. The indirect effect could be through the improved energetics to the cardiac myocytes, decreased sympathetic nervous system outflow, increased erythropoietin, and change in the provascular progenitor cells, and improving the renal function. We know that the heart and the heart are basically having a crosstalk, and if the renal function improves, the cardiac is also benefited. Now this shows all the three SGLT2, CANA, DAPA, and EMPA. You can see the effect on the GFR. There's an initial decline in the GFR, which basically returns back to normal within 3 to 4 weeks, and then it is sustained. In compared to the placebo or the active comparator, you find that the GFR is maintained for the duration of the drug is being used. We still have data for around 4 years, which has shown that the GFR will be maintained on the use of SGLT inhibitors. Now the question comes, if you look at the pathway of blood glucose leading to the diabetes kidney disease, one of the pathways basically through the SGLT2 mechanism. We know that the diabetes patient kidneys have a hyperexpression of SGLT2 transporters. They reabsorb glucose more efficiently, and with that they reabsorb the proximal, they will reabsorb the sodium, leading to less sodium delivery to the distal part, which will increase the outer dilatation of the afferent arterioles, leading to more hyperfiltration. We know also that the glycemia also leads to the more expression of angiotensinogen or angiotensin 2, which will have an independent effect on the increased albumin excretion, or increasing the effective extracellular volume, leading to more blood pressure. They all play a very important part in the progression of diabetic kidney disease. Now, this cartoon shows you the effect on the tubular feedback. Now, if you look at the lower one, that shows what happens in a diabetic patient. you see that is the B part. They show them the diabetic patient. We have the more expression of SGLT receptors. They reabsorb the glucose. They also reabsorb the sodium. With that, we see that there's a decreased sodium flow to the macula densa, which would alter the tubular-glomerular feedback, and you will find the afferent arterioles with the glomula will dilate, leading to more intraglomerular pressure, leading to more GFR. Now, with the use of SGLT2 inhibitors, we know that the glucose absorption is blocked, so leading to blockage of the sodium absorption also, leading to more sodium delivered to the peripheral distal tubules. Now, which will basically will lead to the breakdown of ATP and release of adenosine. Now, adenosine is a very important vasoconstrictor for the afferent arterioles, leading to a decrease in the glomerular pressure and decreasing the intraglomerular pressure and decreasing the GFR. Now, this basically shows the same effect in type 2 diabetes in the early nephropathy. You can see that not only it's the part of the glomerular, afferent arterial glomerular constriction, there is some effect of the prostaglandin being released, which may have a effect on the efferent vasodilatation, which is very similar to what we see in the ARB patient. They also have an effect on the fibrosis and the oxidative mechanism, which leads to glomerular injury, which also basically is inhibited by the use of SGLT2 inhibitors. These were very well seen in the diabetes DAPA-CKD trial, and you can see that the patients were diabetic or non-diabetic, and they had increased urine albumin excretion, they had decreased GFR, and they were randomized to DAPA or placebo, and they had looked at the primary outcome was to look at the composite endpoint of sustained decrease of GFR of 50%, end-stage kidney disease or renal or CV death, and again you see the benefit was very clear. The composite endpoint reduced by around 39% in patients using the dapagliflozin. Again, if you look at the specified groups, whether patient had diabetes or no diabetes, whether patient had baseline albumin excretion or no albumin excretion, normal GFR or decreased GFR, they showed the benefit of using the SGLT inhibitors in a patient with already having existing kidney disease. The last part, not really well studied or well documented is the effect on the NASH. Now, if you look at the systemic review article, they initially included the 5 studies, and they looked at the various parameters, not only the cardiac liver enzyme, which showed a definite benefit of use with the SGLT inhibitors. They looked at the fibrosis, and they also looked at the fat mass being looked at through various mechanisms. They also looked at the liver to spleen ratio and radiology. All basically showed that the use of SGLT inhibitors did have a benefit effect on the progression of non-alcoholic fatty liver disease into diabetes. We all know that very important complication of diabetes coming up is the NFLD causing the cirrhosis and leading to liver failure. Meta-analysis was published around a couple of months back. They had looked at the MRI-based technique of looking at the fat in the liver system. And you can see that, and they'll also look at the liver stiffness by the various elastography. And you can see that very clearly it shows the benefit of the SGLT inhibitors in this type 2 diabetes patients. This shows the nutshell of the beneficial effect. You can see that there's an initial effect of natriuresis and glycosuria, which will lead to better glycemic control, negative caloric balance, leading to weight loss, which could mobilize the pericardial fat. Loss of pericardial fat has a decreased inflammation and fibrosis in the myocardium, leading to better myocardial viability. The better glycemic control again will lead to decreased inflammation, and decrease in the uric acid level again will decrease the plasma uric acid, again has a very important role to play in atherosclerosis. Decline in blood pressure, decline in the endothelial dysfunction also has a beneficial effect on the cardiac remodeling. The tubular feedback is changed or altered, leading to more of vasoconstriction of the afferent arteriole, leading to decreased intraglomerular pressure, leading to more decrease in the better kidney profile. The decrease in plasma volume and the angiotensin 127 pathway also have an effect on the cardiac remodeling and the cardiac protection. So we can say that basically, if you look at the benefits of SGLT2, we know that there are some class effects because the structure is quite similar. They have similar kind of action. They have similar glycemic effect. The heart failure, diabetic kidney disease, and you can see the NASH basically looks to be a class effect. MACE, we are not very sure. I think that has to be still further studied. And with this, I would end my presentation. And if any questions or discussion.
Well, Dr. Mehrotra, I think that was an excellent presentation. And you really told us what exactly pleiotropy means. Pleiotropy is an effect more than one. So with the SGLT2 inhibitors, you have clearly shown through your presentation the varied number of effects that SGLT2 inhibitors have. And to add to your point, or rather to complement your point, when we look at the DAPA-HF trial in patients without diabetes, you could see the effect, the favorable effect, and a significant reduction in relative risk with respect to patients who did not have diabetes as well. That itself speaks volumes about the pleiotropic effects of SGLT2 inhibitors. I think the presentation was extremely good, and you brought out the points very well, and you went into a micro dissection level and showed how in each organ, the kidney, the heart, and also to the metabolism, how exactly the SGLT2 inhibitors are effective in terms of their pleiotropic effects. So congratulations to you. You have done an excellent work, and I hand it over to the organizers. Thank you so much for your lucid presentation.
Thank you, sir.
I thank chairpersons and the speakers for the excellent session. Thank you very much, sir. And just a message to the delegates. They can type their queries in the question and answer chat box in the website. So the chairperson will coordinate with the speakers for their queries, and they will get answers from the speakers. And so we can move on to the next session, which will be shared by two of the very senior endocrinologists from Tamil Nadu and Andhra Pradesh. So to chair this session, I welcome Dr. S. Sridhar, who has done his DM Endocrinology from AIMS, and he was our past president in the Endocrine Society of India, Tamil Nadu and Puducherry chapter. And at present, he is head of the department of the endocrinology department in Miyot International Hospital, Chennai. And he has presented various papers in Index Journal. And he was also the winner of the Best Doctor Award from Tamil Nadu MGR Medical University 2012. And next is Dr. R.P. Mathur. So he is very, very senior endocrinologist, one of the senior most endocrinologists in the country, and also senior most endocrinologist from the Andhra Pradesh. He has done his MBBS graduation and MD from Osmania Medical College, and passed his DM from Institute of Medical Science, Varanasi. After that, he has worked in almost all the premier institutes in the Andhra Pradesh, like Andhra Medical College and Kurnool Medical College, Gandhi Medical College, etc. And he retired as a professor and HOD Department of Endocrinology from the Osmania Medical College. So over to the chairpersons and speakers. So I request Dr. Sridhar to introduce the first speaker of the session and introduce the session also. Sridhar sir, over to you.
Good morning. I thank Magna and Dr. Shanmugusundar and his colleagues for kindly inviting me to this prestigious conference. And the topic today, which we are going to discuss, is about the inertia in diabetic insulin management, and also simplifying the complexities of insulin treatment. And we all know diabetes is indeed a original pandemic. Of course, we are having a second pandemic now. And what people don't realize is that diabetes is a persistently progressive disease, and it requires constant watch. And we have, of course, various types of insulin therapy. We have basal bolus insulin therapy. We have premix, which is more popular in our country. And of course, when there's failure of oral hypoglycemic drugs, we generally start with the basal insulin therapy. What I notice in our country is that once they start the basal therapy, both the doctor and patient lose interest. And after that, there's no follow-up. And as a result, although the fasting sugar is controlled, the HbA1c keeps rising because the postprandial is not controlled. Similarly, premix, once given once, the dose is not followed up. And sometimes we find, despite the premix use twice a day, still the control leaves a lot to be desired. To analyze this and tell us more about this is none other than Dr. P.K. Jabbar, MD, DNB, DM, DNB, and FRCP. He is the professor and head, Department of Endocrinology, and director, CEO, Indian Institute of Diabetes, Trivandrum. He was the chairman of the ESICON in Trivandrum in 2017 and was the organizing secretary of the RSSDI in 2010. He has contributed to many textbooks of medicine and has 53 papers in various index journals and has presented papers in various endocrinology meetings. He has been a regular examiner for various universities for DM and DNB examination, a medical council inspector, and a DNB assessor. I am sure we are in for a feast. Without further ado, it's over to Dr. Jabbar.
So you can share now, sir. Jabbar, sir.
Yeah, I'm trying to do that.
Okay.
So please try again.
Yeah. I'm just looking for my slides here.
In your presentation first. First, you open your presentation, sir. Then
Yes.
click on share screen.
Just a minute. Just a minute. I'll do it. Now it's open.
Now you click on share screen in Zoom.
Yes.
And select
It's
your.
okay, right? It's coming.
Yes. Now full screen.
Yeah, it's coming.
Perfect, sir. Go ahead.
Yeah, it's coming. Good morning, everyone. Regards from Trivandrum, God's own country. Respected Chair, Dr. Sridhar and Dr. Matthews, the senior persons. First of all, I should thank Magna, Dr. Anandan and Shanmugam for giving an excellent opportunity for discussing this brief topic in front of you. A small disclaimer, say I'm a medical advisor to Novo Nordisk company for their presentations, and my plan here is only 3 simple issues. Number 1, what is this inertia, therapeutic inertia, and I'll be discussing Indian scenarios and need of total control of diabetes and balancing glycemic needs through insulin co-formulation. These are the only 3 topics I would like to discuss for today's discussion. Brief introduction to the topic. I want to highlight here lot of death. Even if you remember, if you see the data from Kerala government, most of the death in COVID or due to COVID is partly or completely contributed by our diabetes mellitus also. Yet another saddest part of the story here is around 52,000 crore rupees is being utilized for the management of diabetes and other related issues. And what I want to discuss, 2 more things here. Relatively younger onset of diabetes and longevity is likely to extend, but the problem is if they're getting diabetes, that too uncontrolled diabetes mellitus, that longevity is not really picking up, it's coming down. Higher insulin resistance and more insulin secretory defects. These are the peculiarity of Asian patients. That's a message I wanted to convey. If you see the reality, ground reality, Dr. Sridhar was discussing the difficulties and complexities in the management of type 2 diabetes mellitus. These are the data from our India. This is DAB-CAT study published probably 10 years back. Only 19.7 or less than 20% of the patients, their glycosylated hemoglobin is under control. Immediately after 8 years, you got another study. The study is known as TIDE study. Again, there is no much difference in the normalization of glycemic control. 23.4% only, they're getting good control. If you look into the other studies, like in a CAR study, again, the figure is coming down. These are the complexities. Where to play, I do not know. But these are the reality. These are the clinical reality. We should address that. This is our own data, ICMR data. ICMR data is 24.6% have a percent of the patient has got good control, and remaining around 75% of the patient, their glycemic target is not achieved. They're not touching the magic figure of 7%. Now, here is the term of inertia, something known as clinical inertia, therapeutic inertia, and I would like to add another name for the inertia, clinical myopia. What is happening in the clinical inertia, you know the facts, but we are not intensifying the treatment. We are not advancing the treatment, maybe due to many reasons. The failure of intensify the treatment or advancing treatment, that is very important in our clinical practice. We have a lot of contributing factors for that. Those contributing factors should be addressed. Then only we can increase the glycosylated hemoglobin control group of patients. And clinical myopia, again, we know the facts, but things are not happening. So that is what is happening in clinical myopia. No, there are factors from physician side, there are factors from patient side also. What are the factors in patients, physician side? Overestimation of injection fear. The people, I know that there are a lot of patients that are asking for insulin immediately after diagnosis, but of course the number is very less, but still we are also overestimating the injection fear. Adherence part, we are having definite concern with all those things. Self-management skills also there. So what I want to tell you that there are contributing factors for physician side, and you don't have much time to sit with the patient. In Diabetes Institute, daily we used to see 300 patients with the diabetes mellitus. There is no sufficient time for educating the patient. Even though we have educated, diabetic educated, I personally feel that you should educate the patient, which is not possible in our clinical practice because of busy practice. I want to introduce one more terminology here, 40s. What is 40? Training problem, lack of time, and fewer tools we have, and lack of full-fledged team, maybe nurse, maybe educator. So these are the physician-related factors for therapeutic inertia. There are patient factors also, which is very important, I feel. So certain patients feel that insulin is the last resort, last treatment for the diabetes mellitus. In fact, I remember one of the patients came to me from Saudi Arabia, and he wanted to take insulin, but he doesn't want to take insulin because he feels that as the moment you start insulin, the countdown starts. So such type of myth or misperception concepts are there among patients. They're thinking about the other side effects like hypoglycemia, not at side effects, but if you have good molecule, good setup, good education, good adjustment in life, definitely you can reduce all these complications. Even the hypoglycemia was a very common issue. I remember when we were using classical NPH insulin or other type of insulin, the hypoglycemic episodes were very high. And the people think that insulin can produce blindness, insulin can produce kidney disease, insulin can produce more amputation. So all these misconceptions, what is the net effect? Net effect is psychological insulin resistance. Please read here, psychological resistance. And social stigma is also definitely plays a role for this therapeutic inertia. Now, how to overcome? Don't read the entire slide material. What is written here, sit with the patient, educate the patient, get the confidence of the patient, start appropriate and beautiful molecule which will address all the problems or demerits of insulin treatment. That is the only message from this complex slide. Forget about that. Now, the first part is over therapeutic inertia, which is very common in our clinical practice. Now, let us discuss the second point. What is the second point? Indian issues and need of total control. I'll be discussing that. This, if you look into the data, all these data are well documented regarding the carbohydrate content of our Indian food, especially South India, Tamil Nadu, Andhra Pradesh, and Kerala. We are all consuming a lot of carbohydrate. Carbohydrate is becoming a villain, real villain, because carbohydrate is linked with our NAFLD, non-alcoholic fatty liver disease. For diabetes management is also high carbohydrate diet is producing a lot of complexities. What is written here, you can see the east part, western part, and North India, South India, and Central India. The red zone is your carbohydrate. See the percentage of carbohydrate. The percentage of carbohydrate in average Indian diet is somewhere around 60 to 70%, which is not acceptable. Even though you can change, we should try to reduce the carbohydrate content in our diet. That's a message I wanted to convey. The situation is same everywhere. Pan-India carbohydrate, the content is very high, whereas Western population, your content is probably less than 40%. So is it the reason for good control in Western population? I don't know. That is not the reality, at least. Now, here, what I want to show you that all the time you are in postprandial phase, most of the time. So you can see here postprandial phase. This is postprandial phase. You are in the postprandial phase here, and the post-absorptive fasting phase is only very small percentage of life. So message is we are almost all the time you are in postprandial phase, and the postprandial hyperglycemia has got definite impact on the vascular tissue, cancer issues, cognitive issues, micro as well as macrovascular complication. Indian scenario, as I discussed earlier, scenario is very, very bad because of high carbohydrate diet. So our treatment strategies that should address both meal-related and fasting hyperglycemia for optimum glycosylated hemoglobin control. That is your magic figure of 7%. My friends, see what is this is the Monier's data. Whereas Asian patient in each glycosylated hemoglobin, postprandial glycemic the contribution is very, very significant. Here you can see it's around 70 or 73%. Even if the patient has got very high levels of glycosylated hemoglobin, you have significant contribution from your postprandial hyperglycemia. This is in contrast to your Monier study or Caucasian or Western population. So my friends, for Asia, for India, for Kerala, what I want to tell you that you have significant contribution from postprandial hyperglycemia. That is the message. Here also, this is Mohan sir's paper. What is shown here, this is your glycosylated hemoglobin. The contribution, this is blue line, contribution from postprandial hyperglycemia, my friends, it's very, very significant. You should address postprandial hyperglycemia. Of course, you should address fasting blood glucose also, but for a total control, beautiful control, super control. In all these studies, what is shown here, postprandial hyperglycemia is very significant. So you should address postprandial hyperglycemia very, very religiously you should do, then only you can achieve the magic figure of 7%. Now, what is your issue with postprandial hyperglycemia? At least 6 or 7 studies you can read from the literature. You have Hune study, Paris prospective study, Honolulu study, Chicago heart study. All these studies showed that postprandial hyperglycemia is independent risk factor for vascular disease. So you should address postprandial hyperglycemia. This is one study which showed if the glycosylated, the carbohydrate content is significant, as you can see here, the total mortality is high compared to those who are taking fat. So what I want to tell you that at any cost, please try to reduce the carbohydrate content and try to reduce cues of postprandial hyperglycemia for a better control in terms of glycosylated hemoglobin and vascular health. Coming to the microvascular disease as such, Nephropathy is also linked with postprandial hyperglycemia. Neuropathy is also linked with postprandial hyperglycemia. And there are other issues like, cognitive dysfunction and significant vascular inflammation, and the oxidative stress is also significant. So take a message. See, the only one message is postprandial hyperglycemia is a significant issue in terms of vascular disease. Now, we will look into the Indian scenario again. High carbohydrate diet, high postprandial hyperglycemia. Most of the patients are not controlled on multiple oral drugs, and we have to have a very simple, convenient protocol for our patient. That is the message. Now, let us examine the American Diabetic Association recommendation. The American Diabetic Association recommendation says that if the patient shows failure to oral hypoglycemic agents, you go for a basal insulin. So if you are giving basal insulin, what will happen? For theoretically, definitely this basal insulin will correct only fasting hyperglycemia, not the postprandial hyperglycemia. So basal insulin, not a suitable agent if you are taking a lot of carbohydrate. Offer direct control on postprandial hyperglycemia is not there for your basal insulin. Delayed insulin treatment is also happening. So better you go for control of both phases, fasting as well as postprandial hyperglycemia, by giving appropriate agent for the treatment of diabetes mellitus. So if you are controlling these two, definitely you can achieve 100%, you can achieve your glycosylated hemoglobin to a good extent. That is the take-home message from me. So this is one paper, the basal insulin. What is shown here, the conclusion, the bottom line is around 3/4 of the patient treated with the basal insulin is not showing good glycemic target in real world data. That is a message from this paper. This is published in Diabetic Research and Clinical Practice. This is yet another paper showing that Asians are not achieving good glycosylated hemoglobin. What is written here? Less than 7%, that is your target. So Asian population compared to your non-Asian population, they are not achieving good glycosylated hemoglobin from this paper. Now, the third point, the second point also finished, balancing the glycemic needs through insulin co-formulation. You should address fasting, postprandial, glycosylated hemoglobin. And basal insulin, that will control your fasting blood glucose, and no control on postprandial hyperglycemia. So you need to have a good control. Don't think that insulin is the treatment for postprandial hyperglycemia. Treatment start with your dietary modification, reduce carbohydrate, add fiber, reduce multiple foods. Then if the patient is not showing good improvement with your good oral hypoglycemic agents, you can go for co-formulations or other molecules. Unlike AD recommendation, we are all starting mixed insulin, maybe in the form of conventional mixed insulin, maybe in the form of monomeric combinations like Novamix. Now you have another molecule for controlling both fasting as well as fasting hyperglycemia. You have the Rhizodoc molecule, which is very convenient, and I don't want to discuss the pharmacodynamic property of this molecule. This molecule that will get associated and slowly that will get into the system, see like this, but aspart will get released soon, and that will reduce the postprandial hyperglycemia, and subsequently fasting hyperglycemia is reduced by your the Tresiba molecule contained in the Rhizodoc. That's a message. This is very good. Now coming to the evidence-based medicine, there's a comparison between Rhizodoc and glargine insulin. What is shown here, these are the 4 points which we discussed. This is the data for your glycosylated hemoglobin. Control is better with your the Rhizodoc. Here you can, as expected, postprandial hyperglycemia reduction is very, very significant with your IDEC ASP. What is here? What is shown here, the fasting blood glucose content, it's okay, more or less comparable with your counter or the comparator. And risk of hypoglycemia, my friends, that is the concern, nightmare of a physician and patient and the relatives. So if you go for this type of molecule, you can see the reduction of see nocturnal hypoglycemia, very important achievement in terms of our peace of mind, I would say. Now, here, what is shown here, in patient uncontrolled or hypoglycemic agent, insulin initiation, you can reduce the inertia, you can reduce the resistance. What will happen if you are going for 3 or 4 injections initially? Patient won't accept. So if you are giving this type of injection, co-formulation or mixer insulins, definitely the acceptance will be good and patient will take insulin. So what is shown here, and I say good number of patients, they are achieving glycosylated hemoglobin control with the IDEC as good number. It's around 70 or 75% of the patient, they are achieving your magic figure of 7%. Now, this is a classical method. Here, this is your classical insulin molecule. This is your with the IDEC as. So very acceptance is very good. Patients fear you can reduce, especially there are good devices now. So the acceptance is really good in our clinical practice. That is my experience also in my clinical practice in Indian Institute of Diabetes. Now, these are the recommendation, practical recommendation by our own society, RSST Endocrine Society. What is written here is, to begin with, you can give one single shot that will control in the initial phases. If the blood sugar is not controlled, you can escalate the dosage. You can go for 2 injections also with or hypoglycemic agents. I think control is not bad. So you have evidence-based medicine also. You can, or we can start using this type of molecule for our patient for achieving good glycosylated hemoglobin. My dear friends, ladies and gentlemen, what I want to tell you that take a message. Only points you should remember. Therapeutic inertia is very, very important in our clinical practice for diabetes management. Indian reality, always remember, carbohydrate content is a big issue that is becoming a big villain for producing uncontrolled hyperglycemia. And there are other issues like an NFLD, etc. So if you have good molecule, definitely you can control postprandial hyperglycemia. Mind you, the first and the foremost important issue you should address is your dietary modification. Then good molecules are there, and subsequently you can go for this type of co-formulations, not the basal insulin alone, for a good control on your diabetes mellitus. That would be the carrier message. I think that's very happy to talk to you, and thank you very much for patient listening. Thank you very much. I'm signing off for the time being. Thank you.
I thank Dr. Jabbar for an excellent lecture. And to summarize in short what he said, he presented the pitiful scenario of the Indian diabetic scenario where the control is less than 20%. And he analyzed the various types of inertia, the physical inertia, the physician inertia, the patient inertia, the psychological inertia, etc. And then he lay open and the types of the type of the Indian diet, where much against the recommendation, the reality is 61 to 70% carbohydrate diet. And after that, he also stressed the importance of postprandial sugar in the Asian population, and how we are different from the Munier's equation, and that even at higher levels of HbA1c, the postprandial sugar is contributing to the glucose. And then he showed us the futility of starting just the basal insulin without controlling the postprandial sugar, and then the options available, including IDA-GASP co-formulation, which is helping to, as a single dose, to control both the fasting and postprandial in a more appropriate way. All in all, I congratulate Dr. Jabbar for a splendid job, and now I invite my co-chairman to take over the proceedings.
Thank you very much. I think my video is muted. Can you unmute my mute, please?
Yeah, it's unmuted, sir.
No, it is muted.
Sorry.
Okay, anyway, photo is not important. Dear friends, you had a very beautiful lecture on intensification of insulin, and the various aspects have been discussed. Now a totally different topic which we are going to discuss now is osteoporosis. And we know that osteoporosis is one of the most important cause of bone fractures, both in men as well as in females. It could be primary osteoporosis, or it could be secondary osteoporosis, and it could be because of various factors like hypogonadism, hyperthyroidism, malignancy, and drug induced. And we have a lot of drugs at our disposal for the management of osteoporosis. And what is latest in the management of osteoporosis, we want to hear from the eminent speaker, and Anil Bansali. He is one of the senior most endocrinologists. I remember he was a co-examiner with me in one of the DM examinations, and he is academically very sound. You know his academic qualifications. He did his MD DM from PGI Chandigarh, and he did his FRCP from Glasgow. His area of specialization is in diabetes and endocrinology. He has more than 35 years of experience. He has got a lot of teaching experience. Even at that time when I was in PGI Chandigarh, he was one of the teachers there at that time. So he has got a lot of research experience, and he has got number of publications. We can go on narrating more and more about it, but I don't think it is required at this juncture. So without wasting much time, I invite Dr. Anil Bansali to take over this session and start his presentation today. Over to you, Dr. Bansali.
Open the presentation first and then share screen.
Okay, you are able to see now?
No, sir. You have to open the PPT first, then share screen, sir. Press share screen. So open your PPT, then press the share screen.
PPT.
Dr. Bansal, are you trying from your laptop?
Yes. Share screen. Not able to share the screen, Sundar?
Are you open the PPT, sir?
No, I have not opened the PPT. I am just asking for sharing the screen.
No, you just open the PPT first, sir. Then press share screen. This one, sir, button.
Okay, I open the PPT now.
Yeah, now in the Zoom, press the share screen button, sir.
Yeah. No, I think not happening. I open the PPT, and then I am for sharing the screen. I am switching, clicking that, but it is not opening.
So, are you on your laptop or on your mobile?
No, I am on laptop, sir.
Laptop. Do you see the Zoom window?
Yeah. Now
it's working, sir. Yes, sir. Yes, sir. Done.
Yeah. This is also.
Yes, sir.
Now it is okay?
Yes, sir. Yes, sir. Done, sir. Your voice and video is clear, sir. You can start, sir.
Here, and now I will open the points. Yes, right. Full screen.
Full screen is visible, sir.
Yes. Okay. Full screen is visible, huh?
Yes, sir. Yes, sir.
Okay. Thank you. Thank you, chairpersons, for very kind introduction. And thank you, the organizing team from Magna, for inviting me for this annual meeting. And I'll be talking about the osteoporosis, the diagnosis and long-term management. Since this is a very new area and many things have evolved over the years in the management of osteoporosis, I think that's why it will be worthy to know about these changes or these new developments and innovations which has happened in last decade. So I will be summarizing before you and presenting as a case-based approach. For a diagnostic modalities for osteoporosis, we have got so many modalities now. I have just summarized the DEXA is for bone quantity, the TBS, that is a trabecular bone score, or a QCT, that is a quantitative CT for the bone quality, the X-ray for incident fracture, the FRAX is for the calculation of fracture risk, and histomorphometry for the bone dynamics. For a diagnosis of osteoporosis, we all know that the X-ray has a very poor sensitivity. Only when you have a 50% of the BMD is lost, then you are able to see on X-ray. The DEXA is considered as a gold standard. However, many things have been added even after DEXA, as I mentioned, as a trabecular bone score, TBS, and QCT. In postmenopausal women or a man above 50 years of age, the T score of less than 2.5 is osteoporosis. The T score between -1 to -2.5 is osteopenia, and T score more than -1 is equivalent to normal BMD. However, in a premenopausal woman, we consider a G score rather than a T score, and the G score should be less than -2, and it is called as a low BMD rather than osteopenia or osteoporosis. This is to illustrate the correlation between the BMD quartiles and the incidence of hip fracture. And as we can see, and it is very clear here, is that higher the BMD, the lowest is the hip fracture risk. So that I think very well shows that the BMD is a surrogate marker for the hip fracture risk. And you can see that higher the BMD, lesser is the probability of fracture. Another modality which I mentioned about the trabecular bone score, which assesses the quality of bone. And here the importance is that in many scenarios, the BMD may be normal. Like in acromegaly, we find a BMD is normal, but the TBS is down or TBS is low. Similarly, in patients with type 2 diabetes, the BMD is usually normal, but the TBS is low. That's why they have got a higher propensity for fracture. So what it shows that even someone is having an osteopenia with a normal TBS, they will have a similar risk of fracture in a person who is having a normal BMD but low TBS. So meaning by that, for a good bone means both qualitatively as well as quantitatively, you should have a normal BMD as well as a normal TBS. Then and then the fracture can be prevented. The question comes here, why we should have a long-term management? We have talked about a long-term management for all non-communicable diseases, including diabetes. So here for osteoporosis, the things which are emerging is it's a progressive and it's a cumulative disease. You start losing your BMD from the age of 30 years onwards. The usual decline is around 2 to 3% BMD per year. So, and it's outcome of increasing longevity as the lifespan has increased from 20 years we had way back in 1920 to 2020, we have around 72 years for the man and 70 years for the woman. So such a tremendous change in the longevity has really led to the accumulation of this osteoporotic bone and eventually fracture. Then major osteoporotic fractures are associated with considerable morbidity and mortality. Concurrent diseases like type 2 diabetes and so many drugs you use, they have a great impact on osteoporosis. And lastly, the legacy effect, which we talk about in diabetes, that you control the disease for a short time and you reap the benefits even in the long run, even if you discontinue the good glycemic practices, has not been shown in patients with osteoporosis. So you treat effectively, the beneficial effect is going to last long. So indications for treatment includes the fragility fracture, whether it is a clinical or morphometric, hip or vertebral, the BMD T score less than 2.5, 10-year fracture risk with osteopenia, if more than 3% for hip fracture and 20% for major osteoporotic fracture. So these are the indications for the treatment based on the availability data from the Western population and some data now from Indian population also, that we should treat for following indications. Available therapies are anabolic and anti-resorptive. So we'll be talking about these. And in this group, we talked about the PTH, abaloparatide, and romosozumab from anabolic point of view, and from anti-resorptive, we have the denosumab and bisphosphonates with us. So we'll start with the case one. That's a 65-year female presented with fragility fracture of right neck of femur. She's a postmenopausal for 15 years on intermittent calcium and vitamin D. She's ambulatory till she sustained fracture. That's a very important, that she's ambulatory till she sustained fracture, because it has got a clinical relevance, which I will explain you. No parental or personal history of fracture. Occasionally goes for a brisk walk. Calcium profile is normal. Vitamin D is low, as expected in majority of people. And the T score is minus 2.8 at neck of femur and minus 3.2 at lumbar spine. So what to do next? So first is she should be surgically intervened, because she was ambulatory a day prior to fracture. So if she is surgically operated upon or intervened, then she will be again able to walk faster. We should not wait to treat osteoporosis and then go for a surgical intervention. Surgical intervention should be immediate, as the patient was ambulatory a day prior to fracture. Continue with calcium and vitamin D supplementation. Now the choice, because you have got the same like a plethora of anti-diabetic medications. You have got now plethora of anti-osteoporotic medications. So you should start with anabolic, you should start with resorptive, and now the data are emerging for even you can use a combination treatment. We'll quickly review in 5 slides why you should use an anabolic therapy, teriparatide. It's recommended as a first-line therapy after fracture. That's very important because it improves callus formation. It decreases fracture healing time, it increases osteoprotoxenine, decreases sclerostin, and increases cortical porosity, but improves overall bone geometry and strength. What I mean by the last meaning of that, it increases cortical porosity. So hip BMD in fact goes down after using teriparatide because of the endosteal resorption and exosteal apposition. As the BMD goes down, but overall the geometry improves. So improvement in this bone geometry leads to decrease in fracture risk even after using teriparatide, despite decreasing BMD. So I think that's a very important to understand. So it does not make any that BMD is going down. So that's why we should not use. We should use, because the teriparatide has got many other advantages beside the improvement in callus formation. So this is the effect of teriparatide on fracture healing. So you can see this forest plot. This is all towards the left side. So that suggests that there is a improved favorable effect of teriparatide on fracture healing. One can very well argue, can we use bisphosphonates in a patient who is presented with a fracture? Because many patients may refuse not to use the teriparatide for a period of 1.5 to 2 years. Yes, the data for blood pressure, bisphosphonates and fracture risk reduction, you can see that there is a reduction in vertebral as well as in fracture, but the bisphosphonates do not have a proven significant impact on fracture healing. That's why they don't have a detrimental effect, but they don't have any beneficial or a favorable effect on fracture healing. That's why the bisphosphonates, they lag behind the teriparatide after a patient who presents with fracture. Now the concept is coming from a combination therapy where the people have used a combination of a teriparatide and denosumab together. People have also used a combination of a teriparatide and zoledronic acid, but you can see that if you use a combination of a teriparatide 1:34 and zoledronic acid as a combination, you don't achieve a greater benefit what you have with zoledronic acid alone. But if you use denosumab along with teriparatide, yes, you at least achieve around 5 points increase in, or 5% increase in a BMD at hip. That is a classical which you see with the combination therapy. So you have a definitely better effect when you are using a combination therapy with denosumab plus this. So this is the data from a data study, and which very clearly shows that which very clearly shows that there is an increase in score at spine as well as the score as well as at a total hip. So 9% at the lumbar spine, and a total hip around 4.9%, as opposed to if you use teriparatide and denosumab separately. So combination therapy shows a greater increase in a BMD or significant improvement in a BMD as opposed to individual therapy alone. If you go further, so the preferred therapy in a given case will be the teriparatide, followed by zoledronic acid or denosumab. That's one. And I think the best combination will be combination of the two, teriparatide plus denosumab, because we have got enough data available in the data study. So I think effect of combining anti-receptive and, however, we don't know the effect of this combination therapy on fracture healing. As I mentioned, the callus formation was a feature of teriparatide when it is used alone. But when you use this, but overall the increase in BMD is much higher what you have with teriparatide or denosumab alone, as shown by the data study. So I will prefer the time tested will be RPTH followed by denosumab 1. If someone really dares, he can use a combination therapy for a much better outcome. Let us see a second case where the patient is 70-year female again, presented with a back pain, postmenopausal for 18 years, already on calcium and vitamin D, occasionally goes for a brisk walk, calcium profile is normal, she is osteoporotic, and she has got an asymptomatic vertebral fracture. She has already received teriparatide. So there is an improvement in neck of femur. So at the NOF, there is a decrease, there is an increase in BMD, as well as there is an increase in BMD at spine. However, still it goes in an osteoporotic range, and she has already finished 18 months or 24 months of teriparatide. So what to do next? So one which has to understand that why we should not use teriparatide beyond 2 years. That is what we call as anabolic window. And what do I mean by this anabolic window is that initially when you start teriparatide, there is an increase in a bone formation markers. There is an increase in a bone formation markers, and there is also a very modest increase in bone resorption markers, and both reach a plateau something around at 24 months. So when they reach at a plateau something around 24 months, this period or this window period is called as an anabolic window. And after 24 months, the formation and resorption markers, they reach a plateau. So continuing further this PTH may not be of use. People have tried to explore this anabolic window by using denosumab, something around at 12 months or as a part of a combination therapy. So if you use teriparatide and denosumab to begin with, you can possibly prolong the anabolic window by delaying the increase in bone resorption markers. So if you can delay the increase in bone resorption markers, the time frame possibly may reach up to 36 months. So the anabolic window, so the beneficial effects of teriparatide may continue. So whenever the teriparatide continues its effects in presence of anti-resorptive, it is called as a modeling effect rather than a remodeling. Remodeling means resorption followed by formation. Modeling means only formation. So here we have already inhibited the resorption by using denosumab. So we can prolong this anabolic window by using a combination therapy. So that's the rationale for that. Why do we use for 2 years? So option in this given case is continue calcium and vitamin D and switch to anti-resorptive. The next question is why anti-resorptive should be given after teriparatide. You can appreciate this as soon as you discontinue teriparatide. You can see in a first panel in both spine and hip, there is an increase in BMD. And as soon as you discontinue teriparatide, so like in this study after 30 months, the teriparatide was discontinued, and you have got a rapid decline in BMD both at spine and both at hip, and more observed in female or more faster observed in female as compared to men. So what it shows that, so once you discontinue teriparatide, there is a rapid decline in BMD. And this mainly happens because of the accelerated bone remodeling. If we see further that, here again we see that PTH followed by no medications versus PTH if combined with bisphosphonate, and you can appreciate the change in a BMD after this. So BMD continues to rise if after discontinuation with teriparatide you add bisphosphonates. And similarly shown in this plot, the lumbar spine BMD and the bisphosphonates will discontinue after teriparatide discontinuation. So you had a decline, followed by a rise, but this rise is not equivalent to what you have once you start bisphosphonate immediately after discontinuation of teriparatide. I think that's if you delay it, you don't have so much of benefit. If you immediately put on bisphosphonates, you get a better increase in BMD. Again, question comes whether you should use bisphosphonates after teriparatide or denosumab. So the answer goes more in favor of a denosumab, and you can see that the lumbar spine BMD significantly changed with denosumab. However, on percentage change in femoral neck BMD, it is not significant, but there is slightly or period BMD with denosumab as opposed to bisphosphonates. So now the preferred choice should be a denosumab after teriparatide discontinuation. But again, how long? And the data should study, again you confirm, you focus on the blue points, because the blue points represents teriparatide followed by denosumab, and you can see that these blue points is a progressive rise in a BMD at lumbar spine and as well as at total hip in a patients who has been switched on to denosumab after teriparatide discontinuation. So there is definitely advantage, and definitely one should be on anti-resorptive therapy to achieve or to enhance the whatever you have gained with teriparatide, you can further continue to gain once you add these anti-resorptive measures. Then question is how long you can continue denosumab. So this freedom trial for a period of 10 years shows that you continue to reap benefits by increasing the BMD with denosumab at least for a period of 10 years. But we know that it is a very expensive drug. Every 6 months it has to be injected. If you don't repeat at a time, then you are likely to have a accelerated bone remodeling and vertebral fracture. So one has to be very cautious. So I think we can use for a short time, say 2-3 years till the patient supports, and later on we can switch from denosumab to bisphosphonates once in a year, most economic and inexpensive tool to continue for the BMD therapy. So what after denosumab, once you take a decision to discontinue denosumab, there's an accelerated bone remodeling, there's an increase in BTM, bone turnover markers, so should be treated with bisphosphonates. However, there's one controversy which remains when you should add bisphosphonate once you take a decision to discontinue denosumab. That is, the timing of addiction of bisphosphonate is a denosumab effect is at peak, that is around 3 to 4 months after its injection, or at another means after 6 months. I think that may remain a debatable issue, but otherwise the people prefer to give after 6 months or when the next dose is due. So the preferred therapy in this case will be switch to denosumab, and if patients can't afford or can't take every 6 monthly, then switch to bisphosphonates. I will present the last case now, which is a very common scenario, again a postmenopausal woman, and she has also got a T-score in an osteoporotic range. She has already received zoledronic acid for 5 years, and still, yes, she has gained in BMD, no doubt, but still her lumbar spine remains in an osteoporotic range. So it's a partly bisphosphonates resistance, or partly we can say that this term people have used, that the refractory to the bisphosphonates. So what we should do, and we see so many clinical in our clinical practice, the patients like this who has already received zoledronic acid, what to do in these patients. So options are continue calcium and vitamin D. Now you have the option continue zoledronic acid or shift to denosumab, or you give teriparatide. And lastly, you have a combination of a shift to combination therapy like bisphosphonates plus teriparatide or denosumab plus teriparatide. Let us evaluate one by one. And what we show that bisphosphonates, how long you can give, the continuing zoledronic acid or alendronate for 5 to 10 years and zoledronic acid for 4 to 6 years respectively, you have a remarkable reduction in osteoporotic fractures. However, continuing beyond 6 years, it does not have a much benefit on that. Next, please. And you can see further that there is a horizon pivot fracture trial, that is PFT, horizon PFT, and which shows that if you continue zoledronic acid beyond 6 years, there is a change in a BMD, those who received zoledronic acid for 9 years, but however, it could not achieve the statistical significance. So meaning by that, giving a bisphosphonates or receiving a bisphosphonates for a period of 6 years, particularly zoledronic acid, I think it's a good enough. And after that, you are not finding a response, you are warranted to initiate the other forms of therapy like teriparatide or denosumab. So this is the concept of a drug holiday. So if someone is having a patient with high risk, and these are the categories of high risk, you can continue therapy and annual BMD measurement or alternative therapy may be offered if they have not received for a period of 6 years like zoledronic acid. And those who are without having a much higher risk, they can be reassessed annually and they should be given a drug holiday. So if you are finding that there is a patients, those who are at high risk, you can categorize them. Suppose someone has sustained fracture on zoledronic acid, so they are the high risk individual. Someone has still not achieved the target BMD of less than 2.5, they are at high risk. So they require alternative therapy or they require continue same therapy if they have not received for the full duration. So in this scenario, if you see that the teriparatide was given in these women, and this was they have already received a prior alendronate therapy. And here you can see that at both at a total hip and both at a lumbar spine. If you continue, if you add alendronate, switch or alendronate add, if you add alendronate, you have got a remarkable increase in a BMD both at lumbar spine as well as the total hip. But if you switch to alendronate, then you don't reap so much of benefit. So meaning by that, if prior bisphosphonate exposure someone has received, it may impair a modeling process mediated by the PTS therapy. And however, those who have the reduced BMD at hip, they should be offered add-on rather than switch therapy. So someone has already received this, so you should continue with as an add-on therapy, or you should continue as you should add alendronate to that. So what should be a choice after zoledronic acid, teriparatide versus denosumab? You have it in combination, and those who already received bisphosphonates. So if you see the comparison of teriparatide and denosumab, then you can see that the denosumab does better at total hip and femoral leg, while the teriparatide does better at lumbar spine. So it's a comparison of teriparatide or denosumab in patients switching from long-term bisphosphonate use. So all the three options there. Suppose even after bisphosphonate, resistance of bisphosphonate failure, you are not finding the patient is not able to accept your teriparatide. You can go for a denosumab. You will have a benefits in at least in total hip and femoral neck, and some benefits effect on lumbar spine as well. And next you see that anti-resorptive versus anomaly. We always discuss that even if you fail it with a zoledronic acid or alendronate, you always got an option of a combo. So people have used even a teriparatide and denosumab, those who are showing a resistance to bisphosphonates, and certainly you achieve a much higher BMD when you use a combination as opposed to teriparatide and zoledronic acid as a combination. So the preferred therapy in a case who has already received zoledronic acid for a period of 6 years, switch to denosumab and teriparatide combination should be the most preferable because we have a good data also to show that. However, still the many physicians and even many orthopedicians, they hesitate. So I think another combinations may be the switch to denosumab alone, and I will prefer more switch to teriparatide followed by the denosumab. That should be another combination. So you have so many combinations available for this. And lastly, the word about neotherapies, you have romosozumab. The drug went into some disrepute because of the CVAs, but the data shows the romosozumab does fairly better with as compared to teriparatide, both at total hip and lumbar spine. And you have got another drug, yes, abaloparatide, that is an RPTH, PTHRP, and that also shows that it is a more effective as compared to your alendronate. And next is can you use this therapy in osteopenia? So data again shows that zoledronic acid has been used in the osteopenic women because this is a larger group where you really require intervention and may be beneficial. So this shows that the use of zoledronic acid in a woman who has got osteopenia. So there was a incidence of fracture was reduced, those who received zoledronic acid as opposed to those who received placebo. So to summarize, the treatment naive osteoporotic persons, the anti-resorptive or anabolic, if T score, but use anabolic, the T score is less than 3. Treatment naive osteoporotic patients with fracture. So use anabolic followed by anti-resorptive, and the best combination may be anabolic plus anti-resorptive followed by anti-resorptive. Patients with prior teriparatide therapy with high risk of fracture, then anti-resorptive, preferably denosumab. Patients with prior bisphosphonate therapy with high risk of fracture, anabolic plus denosumab combination should be tried. Or if the patient refuses, then you can use anabolic followed by anti-resorptive. And persons with osteopenia, we have got data only with bisphosphonates. The bisphosphonate is a drug of choice. So thank you for your patience hearing. Hope you would have enjoyed. Any questions or comments, I will be happy to answer.
Thank you, Dr. Bansali. Hello.
Hello.
Thank you, Dr. Bansali, for that excellent presentation. You have talked about the tubular bone score. You have talked about why long-term management and the legacy effect and indications for treatment, anabolic versus anti-reabsorptive. You have presented 3 case presentations and you have given the options for treatment. The first option is, of course, surgical intervention, followed by the treatment with vitamin D. And the advantages of teripeptide on fracture treatment was discussed. The concept of combination therapy of teriparatide and anti-reabsorptive agents and teripeptide, which affects only the spine fractures, whereas denosumab addresses the hip and the femoral neck fractures. You have discussed also about the biphosphonates versus the denosumab data switch study, and what after denosumab you have suggested biphosphonate should be used. The effect of 6 versus 9 years of zoledronic acid pivotal trial also you have discussed, and in the end you have highlighted about the newer drugs like romizumab and albenperatide also.
Albenperatide.
Yeah. So I think it was, and on the whole, a very comprehensive and elaborative presentation, a crystal clear presentation. And if there are any questions from the audience, I think Dr. Bansali will be pleased to answer them.
I think there's a question from Dr. Shanmugha. He asks, what about the usage of bisphosphonates in CKD? Up to what level GFR it can be used? And which is the choice?
Yes. So in a patient with a CKD, you can use the bisphosphonates up to an eGFR 45 ml per day. So the eGFR is less than that, you should not use, or you should avoid rather. Another thing which the people have used bisphosphonate is slightly renal friendly is risidronate. So people have used risidronate for that. Ibandronate, sorry, not ibandronate. So I think that is a more safer. But otherwise, we say up to the eGFR of 45 ml per minute, you should avoid bisphosphonates.
The atypical fracture risk is associated with the denosumab also, like bisphosphonate. But for bisphosphonate, we talk about drug holiday. We have data for that also. But for denosumab, if we stop the therapy, there is a definitely increased risk of spine fracture. So what should we do, or what precaution we should take if we are putting the patient on denosumab, sir?
Yeah. So I think the question is very pertinent because the atypical fracture femur have been described with both. However, we have got more data with the zoledronic acid or bisphosphonate. That's why we have got more data with that of atypical fracture femur. But it does happen with denosumab also. So I think the best is that as soon as the 6 months of the denosumab, the next injection is due, the patients are usually warned and they should put the second injection or the due injections at time. If they delay this injection or the second injection, if it is delayed, then I think then there is a possibly more risk of a accelerated bone remodeling and increase in BTM followed by a fracture. So this usually happens with that. So I think that timely injection has to be done. If the patient is not found to be so compliant and so religious about the management, then I think the best is you shift to a bisphosphonates rather than using a denosumab.
Thanks.
Thank you. Thank you.
I thank the chairpersons and the speakers. So two wonderful talks in this session. So we'll move on to the next session. So to chair this session, I invite the chairpersons, Dr. Vipin Kumar Sethi sir. So he is again alumni from PGI Chandigarh. He has done his MD and DM endocrinology from PGI Chandigarh, and he has got silver medal for outstanding as a student in the MD. And at present, he is professor of endocrinology at Gandhi Medical College, Hyderabad, and consultant endocrinologist at Care Hospital, Hyderabad. He has various publications in reputed national and international journals. And to co-chair him, we have Dr. Arun Badavi. He is a senior consultant diabetologist at Bangalore. He runs his own center, the Sudha, the Preventive Center. And previously, he has worked at Apollo Hospitals, Sagar Apollo Hospitals, and Trinity Art Foundation. And he is a faculty and examiner for various programs for DNB Medicine, Public Health Foundation, India regional faculty, and also various other international programs also. I hand over the session to the chairperson. I request Bipin Sethi sir to introduce the first speaker.
Thank you very much. I have great pleasure in introducing Suresh, whose introduction you can see he's a very active and a very young, energetic individual, and I'm very happy to chair a session with him. He's from Coimbatore, and he has got lots of interest in translating the evidences that we have and connecting with patients through virtual platforms. He's going to talk to us about a topic which is important for control of glycemia in type 1 diabetics. We know that the insulin was first introduced as treatment for type 1 diabetics, and the problem with the insulin was that it was a short-acting insulin, and initially, just for comfort's sake, people had tried to prolong the duration of action insulin so the number of injections can be reduced. That led to disastrous increase in complication that was shown by earlier studies in Malmo. The people who took NPH-based insulin had more complications. But with the newer innovations, basal insulins have come a long way, and I will not come in between you and Dr. Suresh for his presentation. Over to Dr. Suresh for his presentation on the role of glargine in this setting.
Dr. Suresh, will you present or should I play?
Suresh, you are muted.
Just play it, please. It's all recorded already. Thanks, Dr. Bipin. Good morning, everyone. Thanks very much for the wonderful opportunity. Dr. Anandaraman and Dr. Santosh and the whole team of Magna. And thanks for the chairpersons for chairing my session today. So the session is for next 20 or 30 minutes or so. The topic is to drive home the message about the basal glargine insulin, which is like a gold standard insulin that has been there for a while. But how redefining the insulin therapy in the landscape of treatment in over the past 2 decades in India. Now, the important aspect is it is a company talk what I'm doing today. It is for Sanofi, and a honorarium is from them. But I think the concept of basal therapy has been evolving over past probably past decade or so. In India, it's gone up in a big way and it's taken off. I'll show you the data, how it has changed the landscape of the insulin therapy, how people's attitude has been changed from premixes to basal insulin as insulin initiation, and how simple the insulin initiation has become. Previously, thinking about insulin means, it is a big thing. Now we need to refer to a super specialist and specialists like forth. But now I think a lot of general practitioners and physicians, quite a lot of them are starting with ease. Even you can see the junior doctors are starting the insulin initiation as really an easy way to do. It is to do with the education in a lot of conferences. The insulin initiation workshops and other things are going on. But even though the contribution of the science in this area has moved forward, so that the basal insulin has been started, made it very, very easy, so that the landscape has changed. So with that introduction, I'm just going to talk with a clinical scenario. We got a patient which we face up in the clinical setting, hyperglycemia, very bad hyperglycemia, and this patient is on 3 OADs. So for example, the patient name is Mr. Ashok, he's 45-year-old and diabetes for almost 3 years. And he presented to diabetic clinic for a routine follow-up. No history of hypertension or heart disease. Current BMI is 27. And also he's got ophthalmological examination wise mild non-proliferative diabetic retinopathy. HbA1c is about 8.8 as the fasting blood sugar, and the postprandial blood sugar is way above 200. So as I mentioned, this patient is on all triple therapy already. So metformin 1 gram BD and sulfonylurea and also a gliptin. So all 3 drugs are there. And a second clinical scenario, a long-standing diabetic again, the patient name is Ramya, and almost 10 years of diabetes, but peripheral neuropathy is present with burning pain and numbness in feet. However, there is no hypertension or heart disease. If you look at the blood pressure, it's quite normal and not tachycardic or anything. The weight is average, but the eGFR is in 74, but mild microvascular disease indicated by non-proliferative diabetic retinopathy. So as I mentioned, the control is very, very bad here for Mrs. Ramya as well. So look at the fasting and PP, both are above 200. That indicates clearly that 9.2 is the A1C. Now look at the gliptin and metformin is 2 drugs, and then the glimepiride is 3rd drug. Now these 3 drugs are the commonly used up drugs. However, now the SGLT2 comes into play, but AGIs are not that much used, and pioglitazones not that much used. So these are the 3 common drugs that we see in a practice: metformin, sulfonylurea, and gliptin. So 3 drugs are there for a patient 1 and 2. What would you do next? I know my topic is insulin related, but why insulin? And that is the key point that I want you to take as a message from this talk. Now, doctor, why can't, we do 3 drugs and patient would be much more happier if the insulin, the needle is not there. Why can't I go for the 4th drug? I can just add on a OAD or of some sort, like a pioglitazone or anything. But what is the difference? See here in this data, you can see when you add on a 3rd drug, in addition to the 3rd drug, if you add on a drug, there is no change in A1C compared to 3 drugs or 4 drugs. And that is the challenge. Unless you missed out the complete pathology of the disease and went into the wrong drugs initially. Other than that, I think the data showed only 0.3% A1C reduction in both arms. That shows that there is no statistically significant effect when you change the drug, when you add on the drug, sorry. So you can ask me, so 4th drug, you said that is can't be added or no need to add because there is no benefit to it. Why would you consider insulin? If you look at the meta-analysis of a DPP-4 inhibitor trial, 52 weeks trial, the A1C slightly getting deteriorated after some time. And that is one thing with the DPP-4. And if you look at the DAPA study, after 2 years, the efficacy is becoming slightly less. Same thing is observed with all other SGLT2 trials. So indicating after certain time, the drug inertia happens and the drug failure, if you like, even though it's not the mechanism that is fully explained, but looking at it, these data, the efficacy of the OADs is definitely reduced. This is published in 2018. Now, why to consider insulin in these patients? Because if you look at the statistical landmark trial, that is the one trial that I'm going to talk a lot today in this talk. 0.3 A1C reduction in a patient with insulin naive, that's not having insulin. However, when you start having insulin, in this landmark trial particularly, there is 0.6% reduction, which tells you almost there is a statistically significant of p-value of less than 0.01. So landmark is a trial which is like a longitudinal nationwide study in the management on real world outcomes of diabetes in India. Like diabetes in India has been not much more, if you like, the practice is not being evaluated in a big clinical trial, but this is one of the landmark trial. So landmark is named after landmark, showing that the data is so robust to say that insulin starting will be a beneficial thing in the real world setting. This is real world data. So which insulin to start with? So now we are clear. Third drug is there. Adding a fourth drug is not an option because there is not much of benefit. So we are adding on insulin. That much we are sure with landmark trial. Now coming to the point where what insulin is you're going to initiate. As I said initially, the DiabCare study in 2011, if you look at it, the pre-mix insulin is in the orange bar, which shows a huge thing difference of a 52.7 was predominantly used in India. In the decade or so, what happened is, see the next graph. Why before that, I want to show why the pre-mix insulins are very, very, if you like, more popular in India. It is perceived that that will control the postprandial sugars really well compared to the basal thing. And the premix will provide a better glycemic response compared to the basal one. And that is perceived number one. And number two is the high carbohydrate in Indians has made the PPG to go up, and the premix will work better as is another concept. And another last concept is like FPG and PPG are managed both very well with the mixed insulin. And that is the concept of perceived reasons that why mixed insulin was popular. However, that has been changed in the last decade or so. 10 years down the line, past 10 years, you can see the base insulin percentage was initially in the DiabCare studies only 13.8%. Now look at the data in landmark trial, a huge whopping 53.6% of proportion of insulin receiving patients started on basal insulin. As I said, the reasons to it is good knowledge and science spread across this area. Number two, easy usage. Number three, I think the doctors are very confident in using the basal insulin as just one-off thing. And the last one is over the years, the doctor's personal experience has made them to start basal insulin very, very fast. So this is adapted from landmark trial. So my way today is going to be 3 reasons for a paradigm shift. And you know that we, after 3 drugs, 4th drug is not an option. And we decided with insulin. And we said that mixed insulin was popular in India, but it's changed into the basal insulin. Why? And these is the 3 reasons for a paradigm shift that has happened. And you should know this science. So this is the main science that I want to drive across for today. If you can remember this slide. Fixing the fasting first, because fasting, the mechanisms are huge, hepatic glucose output, poor control in the fast, and the overall glycemic memory all contribute to the fasting thing. And then the holistic glycemic control makes a huge difference in terms of reduction of micro and macrovascular complications. And the efficacy, of course, you need to be having an efficacy of the drug and the safety data to make sure it has been used for a very long duration. Now, let's start with the first one, which is called fixing the fasting first. Higher the A1C, greater the fasting, which we know that very, very for a very long time, that if the A1C is higher, the fasting sugar is very high. So look at the fasting blood sugar, which is the blue line, which is contributing a lot for the A1C. And the bars goes from 6 to 6.9 to about 10%. You can see the bar size is increased with the blue one, which is the fasting one, is contributing a lot for the A1C. So we need to fix the fasting first. The FBG with more 7 than millimole is more of a European, it's a millimole description, but if you look at it, it's almost 126 milligram per DL. So if you have a blood sugar of more than fasting of 126 or so, what is the data tells us? It's an independent risk factor of mortality in patients with COVID. So the patients who are admitted with COVID disease, if you have a fasting blood sugar more than 126, the high chance of mortality is there. The mortality rate is 2 to 3-fold increase in the mortality. So you know that now, that we all know that bad blood sugar is not good for COVID, but above 126 in the fasting state puts you at the very, very high risk of getting mortality with COVID. So whatever COVID is a very unpredictable disease. We are all scared of about it, and there are a lot of things that we can't do to change the progress of the disease. However, I think if blood sugar is less than 126, you know you're less risk compared to somebody who is above 126, and that puts them almost 2 to 3 folds high risk of mortality. So as I said, the COVID positive patients are high risk if more than 126 deciliters of blood sugar. So what is the relationship between fasting blood glucose and the risk of being admitted in ICU in COVID-19? I've explained very clearly. Even the small increase within the normal range of fasting blood glucose may be associated with a very high risk of ICU admission in patient with COVID-19. What in the previous slide I showed is the mortality due to COVID is very high when the fasting is more than 126. But now I'm saying the ICU admission rate is high when there is even if you tell doctor 80 is a fasting, 100 is 120 is a fasting normal range. But which one would you like? You want the lowest one, because even the small increase within the normal range itself, the fasting will make the patient to go on the risk of ICU admission. It's almost 15-fold increase. That is a phenomenal amount of fold of increase when you get a poor sugar control to get into ICU. So glycemic target achieved by glargine 100 despite a high baseline A1C. This is like that's the data, almost like 2 years of data by 2003 by Riddle and 2005 by Janka and Gerstein. Herschel is a guy who's done a lot of inpatient work. He's from Canada. And then 2008, Brett Selvan and Matthew in 2015. So there's so much studies have showed insulin glargine attain the fasting normoglycemia. Therefore, the whole A1C is reduced. The glycemic target is really a good one with the insulin glargine. These are the big studies that showed that. However, personally, you and me using glargine for more than almost 15 years or so, we know it's a beautiful drug that works really fixing up the fasting and therefore the whole A1C as a whole. So I mentioned, I want you to remember this slide. I mentioned and I spoke about fixing the fasting first, and I've given the evidences to show how the basal insulin does it. But next one is the holistic glycemic control. So I mentioned about the fasting, but how about the PPG? What happens is once you fix the fasting, if the blood sugar is 140, for example, and you're fixing it to 100, so when you start eating with the blood sugar of 100, there is a high chance that it will go only up to 180 or 190 or 170, something like that. However, if you start with 130, then it goes about 200. So if you fix the fasting first, that the postprandial blood sugar excursion will be much more lesser. So elevated fasting hyperglycemia is the biggest challenge. And if you make it normal, what happens is that PPG comes down very, very nicely. So this graph would have shown you very nicely that if you get rid of it, the sugar comes down in PPG very nicely. So it is called fixing the fasting first, which we done in the last bit of my talk. The last few slides before in my talk. So the basal insulin provides it's a holistic glycemic control in real world scenario. This is the landmark trial again I'm coming to. It shows that almost 6 months of follow-up with the fasting and PP, both PP you can see 228, the blue line, it shows the baseline one, and 6 months later, it controls really well 135 and 190, which is statistically significant after basal insulin. So we want to target the fasting normoglycemia, and therefore the PPG will be perfectly controlled. So the mean 2-hour PPG level decreased from 12.07 plus or minus 1.17 to 8.94. That is quite significant statistically. So these two I've discussed already, fixing the fasting first, and you have to do the holistic glycemic control. How about the efficacy and safety? I'll come to that in a minute. So if you look at the pink one, which is the glargine, and the premix one in the blue one, you can see there is a head-to-head comparison of glargine 100 with premix analog for the efficacy wise. On the other side of the bar, that's a percentage of people achieving the A1C below. So in the pink one, which is the glargine one, attained almost 43% attained the target compared to 12.5 of premix one. That tells you clearly the A1C reduction is quite good, and it shows almost 20% greater A1C reduction in glargine A100 compared to premix. That's a huge A1C reduction compared to the mixed insulin. The lower hypo risk is another thing. So with the basal insulin, we are not having any mixed insulin all over. The risk of hypoglycemia and the risk of weight gain is much, much lesser compared to premix insulin. So the lesser risk of overall and nocturnal hypoglycemia with glargine plus OAD compared to human mixed insulin. You can see in the blue one, which showed 13.3% of hypoglycemia compared to 2.85 of the glargine one. Again, I mentioned about the weight. So the weight gain is also much lesser than the basal insulin compared to the mixed insulin. Almost 50% of lesser weight gain in glargine compared to, that's a huge volume, 50% less weight gain. Doctor, you mentioned about comparing glargine with the mixed insulin. How about glargine versus co-formulation, which is like the Rysodec, which is like basal insulin along with the short-acting one. The A1C reduction is almost comparable, and the fasting is almost comparable. But I think the fasting is much better in the basal alone group of drugs. So the glargine 100 versus co-formulation and the safety, almost the weight gain is almost 36% less in the Lantus arm compared to the Idagasp arm, so which is like a Rysodec. So, so I mentioned about the three things that is fixing the fasting first, and then glycemic control, overall holistic glycemic control, and also about the overall control has to be good. Now, coming to the global, how about the global guidelines? The guideline shows the basal insulin premix, which can be started either way, which can be started in the even the 2012 guidelines compared to the recent one, that premix insulin is out of the guidelines in the ADA 2021. They say just as a simple therapy, you really need to go for basal insulin. So, and the guidelines have changed a lot from 2017 to 2021. All the time the basal was there, but the premix one has been taken off from 2016, 14, and to 14 respectively with other bodies. So it is the trend of the clinical practice that has moved, and the science also moved along with it. I have to say the other way around, the science moved and the people moved along with it, and henceforth the guidelines is also moved in 2021 up to that. So again, coming back to COVID-19 pandemic and the Indian expert panel, they say basal insulin analogs are the simplest way in people. Initially, the COVID was managed only in particular hospitals. But what happened is when the volume increased and increased, a lot of peripheral small hospitals have started catering for the COVID patients. But the challenges with the steroids, the sugar shoots up, and those doctors who didn't have much of experience, they all started with the basal insulin, which is the amazing way to start insulin. And the control is very, very smooth. And the starting dose of the basal insulin is either 10 units or very slow dose of 0.1 to 0.2 units per kilogram per day. So this is what has happened during COVID time and still happening with a lot of doctors. So my last 20 minutes or 25 minutes or so, the initial introduction, what I've given is about the where is the change that has happened recently. So the three drug, I've given two case scenarios to say that three drug combination is there in the patients with poor control. What do you do next? And I've also explained with a lot of science saying that adding a fourth drug, it doesn't bring any difference in the HbA1c reduction. So therefore, and you notice all the people are on OHAs, the potential action and the worsening of A1C becomes very prominent if the patient stays on the treatment of oral OHA for a very long time. So insulin initiation was the best one that has been noted. So that is the second point I brought across. And after noting that insulin initiation has to bring, the third point is to say which insulin. And I've also shown the data showing that how in the DIAP study initially that showed mixed insulin was so popular, and in now the recent landmark study showed basal insulins are a whopping more than 50% has been taken. So I've explained the reasons for why basal has been picked up, simple injections and effectiveness, and also the safety. All these three things made the basal insulin to be taken off by the clinicians very swiftly. And then I brought in the point across saying that the basal insulin has to be having fixing the fasting first, and making a holistic glycemic control, and making a drug which is effective and safe. So I went through each with a landmark trial and fixing the fasting first, and also about the safety of less hypoglycemia and less weight gain through data. So to conclude, merits of glargine 100, which we've been using for almost more than a decade, is more physiological, efficacious, and in COVID conditions more than 126, we can fix that, so that the chance of them dying or chance of them going to ICU will be less. And it's a simple and convenient regime. We can fix the fasting, and that in turn reduces the postprandial, and that in turn reduces the A1C. So this is the preferred drug during the COVID pandemic, and it's supported by the local and international guidelines. I'll stop there and hope that I brought in the message is very clear, that basal insulin is much more safer and efficacious. Thank you very much for the opportunity. I'm happy to take any further questions. Thank you.
Thank you, Dr. Suresh. Dr. Suresh Damodaran, thank you very much for that lucid presentation. In last 20 minutes, you told us many things about insulin glargine, which has got, and gave a roadmap also, why exactly it is good insulin to start with, to stay with. You said that fix the fasting first, then you said about holistic glycemic control. You also gave us, it has got better efficacy and safety profile. You in fact compared it with co-formulation also, and gave a very solid reason why exactly this insulin is better than, as far as the weight gain is concerned, compared to a co-formulation. And last but not the least, you also gave us important information that the recent ADA guidelines does not mention about premix. It mentions only about the basal insulin for the insulin titration. Since the topic has been, topic is on redefining the landscape, I would like to mention that there is one beautiful article has appeared in JAPI December 20, which speaks on this thing, that how insulin glargine is now more should be used in pregnancy and lactation, renal insufficiency, malignancy, elderly population, Ramadan fasting, and obesity. So this glargine being a peakless insulin is and the premier basal insulin. Although there are other basal insulin, but the premier basal insulin and most commonly used is one of the finest drugs to be used in obesity if GLP-1 analogs are not working or to be used along with GLP analog. If there are any questions from audience, Dr. Suresh is there. He would like to contribute to your knowledge or any comments from the audience. If no,
the only thing I want to say is you mentioned about glargine in pregnancy.
Yeah.
Probably in type 1 diabetics, people are on glargine already. We can continue that drug with the query of growth factor stimulating and other things. So GDM and other pregnancies, early type 2s and stuff. Still, I think glargine is not that much preferred compared to the other insulin.
I agree. The point is well taken. That's right. If there are no questions, then we move on to the next topic.
Thank you.
Thank you, Dr. Suresh Damodaran, once again for the
Thank you, sir.
Thank you,
Doctor. Thank you, Dr. Bipin.
I have got the good fortune of introducing to you the next speaker, Dr. P. Sudhakar Reddy from Hyderabad. He is a DM endocrinology and is a consultant in Hyderabad. He's MBBS from Kaktiya Medical College, Warangal, MD from Gandhi Medical College, Hyderabad, and DM from Osmania Medical College, Hyderabad in 2007. He has been associated with various hospitals, Gandhi Hospital and Yashoda Hospital and Sunshine Hospital. And right now he is a consultant endocrinologist for Magna clinics of obesity, diabetes and endocrinology in Hyderabad. Welcome, Dr. Sudhakar Reddy. Dr. Sudhakar Reddy is going to speak on secondary hypertension. And we all know that secondary hypertension is a difficult thing to diagnose. And because we are so used to detecting and treating primary hypertension, that most of the time we forget that this case can give a secondary hypertension. But we should not forget that secondary hypertension constitutes almost 5 to 10% of population of hypertension suffer from secondary hypertension. And there are multiple causes of secondary hypertension. It can be most common being the renal or sometimes the coagulation of aorta and other things. But what we are going to discuss today is the endocrine causes of secondary hypertension. I pass it over to Dr. Sudhakar Reddy to throw some light on endocrine causes of secondary hypertension. Over to you, Dr. Reddy.
Thank you, sir, for a nice introduction. Good morning, everyone. Today, I'm going to speak on this topic, secondary hypertension and endocrine evaluation. So what is secondary hypertension? Basically, it is an arterial hypertension due to an identifiable cause. And this secondary hypertension accounts for 5 to 10% of cases of hypertension. And in young adults, less than 40 years age group, this prevalence of secondary hypertension is approximately 30%. That is significant number. And this secondary can present at young age, unlike primary, and is severe, multi-drug resistant. And most important thing is that target organ damage in secondary hypertension is disproportionate to the degree and duration of hypertension, unlike primary. And why we should evaluate for this secondary hypertension? So basically, we can expect cure after definitive treatment. That is the reason we must evaluate. And for this, high index of suspicion is required, and systematic approach is essential to avoid unnecessary investigations. So this is the JNC 8 Joint National Committee classification: normal, pre, stage 1, stage 2, and isolated systolic hypertension. But before staging or grading of hypertension, measure the BP in ideal condition. These are the common blunders we do in clinical practice. Better not to do. And who should be evaluated for this secondary hypertension? So any hypertension onset at young age, presence of paroxysms and hypokalemia in a patient with hypertension requires evaluation. And in addition, patients with labile hypertension, severe hypertension, and resistant hypertension, that by definition is uncontrolled BP despite usage of 3 and more antihypertensives of different classes in optimal doses, including a diuretic, and hypertension in the presence of typical clinical stigmata of specific syndromes or disorders like Cushing or incidental adrenal incidentalloma with hypertension. They require evaluation for secondary hypertension. And basically, this hypertension is classified into primary and secondary. Secondary again divided into renal and non-renal causes. And in renal, again, renal parenchymal and renovascular causes. Renal parenchymal is the most common cause of hypertension in children. And non-renal causes include endocrine and cardiovascular and other causes like obstructive sleep apnea and alcohol-induced hypertension. And before evaluation, take the detailed history and clinical examination. Definitely, you will get some clue for your diagnosis of secondary hypertension, and so that we can avoid unnecessary investigations. So these are the clinical clues for this secondary hypertension causes. Coming to the renal artery stenosis, young female suspect either fibromuscular dysplasia or autoimmune conditions, autoimmune vasculitis as a cause of renal artery stenosis. But in old age, generally it is part and parcel of generalized atherosclerosis. So background, they will have history of coronary artery disease, a peripheral arterial disease or CVA, and examination, they will have reverse nocturnal dipping, flash pulmonary edema is possible, and there is a hyperreninemic hyperaldosteronism. This is the classic example. Sometimes you may see renal bruit. And basic screening when you suspect renal artery stenosis is renal Doppler. Doppler, if you find stenosis, then next step is to proceed to angiogram. And if there is no stenosis, search for other cause of secondary hypertension. Coming to the obstructive sleep apnea as a cause of secondary hypertension, this is one of the common cause of secondary hypertension. Mechanisms being increased sympathetic activity, RAS activity. They will have excessive daytime sleepiness, snoring, morning headaches, poor concentration, irritability with markers of insulin resistance. And in ABPM, they will have reverse dipping like renal artery stenosis. And the basic screening tool is Epworth sleepiness scale that I will discuss in the next slide. And for confirmation, polysomnography. And for treatment, of course, it is not a permanent treatment, CPAP, you can. This is the Epworth sleepiness scale. We have 8 situations and 4 scores from 0 to 3. For example, sitting and reading, while sitting and reading would never doze off, it is 0. High chances of dozing, it is 3. So 8 situations, 4 scores. If total score comes more than 10, suspect obstructive sleep apnea. So basic screening is this sleep scale followed by polysomnography. So in that apnea hypopnea index, if it is 5 to 15, we consider it as mild, and 15 to 30 is moderate, and more than 30 is severe obstructive sleep apnea. Coming to the endocrine causes of hypertension, this is the simplified classification: adrenal dependent, thyroid dependent, pituitary dependent causes, and apparent mineralocorticoid excess. What are the clues for this endocrine hypertension? Any hypertension in young without positive family history of hypertension, hypertension in the presence of hypokalemia, severe hypertension that is more than 160 by 100, resistant hypertension, labile hypertension, hypertension with background of presence of adrenal incidentalloma, and positive family history of endocrine disorders like men, FIO, better to rule out endocrine hypertension. Then coming to mineralocorticoid excess syndrome, this is the common cause for endocrine hypertension. Mineralocorticoid excess syndrome broadly divided into 2 categories: high renin and low renin. High renin, classic example is renal artery stenosis. They will have hyperreninemic hyperaldosteronism. And low renin again divided into 2 categories: low renin with low aldosterone, that is apparent mineralocorticoid excess conditions, and low renin high aldosterone. Classic example is primary aldosteronism. Primary can be unilateral, bilateral, familial, or genetic. That apparent mineralocorticoid excess I will discuss in the next slide. Coming to the primary aldosteronism, this is one of the common cause of secondary endocrine hypertension and under-recognized and under-screened problem seen in about 5 to 13% of cases of hypertension. What are the recommendations for screening for primary aldosteronism? Hypertension in young, severe, drug-resistant, and most important, hypertension with spontaneous or diuretic-induced hypokalemia always rule out primary aldosteronism. And hypertension with adrenal incidentalloma and strong family history of young strokes, better to rule out this one. And as of now, universal screening is not recommended as the available data do not support the benefit of this screening. Coming to the clinical manifestations of this common cause of secondary hypertension. So manifestations can be of aldosterone excess or hypokalemia. So aldosterone related are like severe diastolic hypertension with target organ damage. Previously, I mentioned that damage is disproportionate to the duration and degree of hypertension. And coming to hypokalemia related manifestations, they may present with proximal muscle weakness, sometimes nephrogenic diabetes insipidus, periodic paralysis, and ventricular arrhythmias. Next, coming to secondary diabetes, like Cushing, even hyperaldosteronism can present with secondary diabetes. This is because of hypokalemia. We know diuretic-induced diabetes. So in that main mechanism is hypokalemia. The potassium is required for insulin secretion. So hypokalemia, which is common in aldosteronism, along with insulin resistance because of aldosterone excess, can cause secondary diabetes. Coming to the screening, in endocrinology, generally any condition, not only the secondary hypertension or primary aldosteronism, generally it starts with clinical suspicion, then biochemical screening, then confirmation, then anatomical localization, if necessary functional imaging, sometimes special investigations. So in primary aldosteronism, screening starts with aldosterone-renin ratio. If screen is positive, you can go for confirmatory testing. Of course, it is not required in every cases. Like for example, too much suppression of renin, too much high levels of aldosterone, and in the presence of hypokalemia, it is not required. And once you confirm by giving saline, IV normal saline of 2 liters over a period of 2 hours, normal physiology, you expect suppression of aldosterone. If there is no suppression, that confirms primary aldosteronism. And next step is to go for anatomical localization by CT or MRI. So if it is severe primary aldosteronism, young age, less than 35, unilateral, clear-cut adenoma of more than 1 centimeter, you can go for surgical adrenalectomy. But if you are in dilemma and if you are doubtful about source of that aldosterone excess, better to go for AVS, that is adrenal venous sampling. If it is unilateral source, better to go for surgical. Bilateral means MRA is the treatment of choice. Mineralocorticoid receptor antagonist therapy. Then what is this apparent mineralocorticoid excess? Normally in the kidney, cortisol will be inactivated to cortisone by 11-beta HSD enzyme, 11-beta HSD2. So any factor which causes deficiency or inactivation of 11-beta HSD2 can lead to high cortisol exposure in the kidney that acts on the mineralocorticoid receptor, and it causes situation like hyperaldosteronism. Typically, they will have low renin, low aldosterone, and diagnosis of this apparent mineralocorticoid excess can be confirmed by high ratio of cortisol to cortisone in 24-hour urinary collection. Coming to the pheochromocytoma, there are so many fancy things in pheo, but it is not that common like hyperaldosteronism. Most common in 4th to 5th decade, especially sporadic, equal in men and women. And the famous 10% tumor for PPGL is no longer tenable. And most of the catecholamine secreting tumors are sporadic with dominant norepinephrine secretion. And familial pheos, most of the times they are bilateral, adrenal in origin, with the dominant epinephrine secretion. Of course, with exceptions like paragangliomas, they will secrete only norepinephrine. Reason being PNMT is absent. That is the enzyme required for conversion of norepinephrine to epinephrine. These are the clues to suspect pheo. 40 to 50% of patients will have typical triad of diaphoresis, headache, and palpitations. Sometimes they may present with secondary diabetes. And depending on the location of the FIO, sometimes in case if it is there over the bladder, they may present with painless hematuria or micturition syncope. And any catecholamine excess, weight loss is possible. And any adrenal incidentalloma with hypertension, always rule out FIO before proceeding further. And after biochemical screening, definitely you will have some clue for your differential diagnosis, like large FIO versus small FIO. Large FIO produces more of metabolites, whereas small FIO more of catecholamines. Sporadic versus familial, if you compare, sporadic FIOs most of the times produce norepinephrine, whereas familial FIOs epinephrine. Of course, there are some exceptions. And paragangliomas, because of lack of this PNMT, phenylalanine N-methyl transferase enzyme, which is required for norepinephrine to epinephrine conversion. So this paraganglioma, which is nothing but extra-adrenal pheochromocytoma, will produce only norepinephrine. And malignant FIOs, most of the times they secrete dopamine and they may present with hypotension. So these are some of the things which are useful in differential diagnosis. Next, whenever you suspect FIO, it starts with screening. If you have low suspicion, better to go for 24-hour urinary fractionated metanephrines, which has high sensitivity. And if you have strong suspicion, high suspicion of FIO, you can go for plasma fractionated metanephrines. More than 2 times elevation is considered significant or screen positive. Then next step is to go for anatomical localization. And in case if you are not finding anything in anatomical thing, that imaging, next step is to go for functional imaging, either by MHBG or PET scan. And if you are suspecting familial or genetic condition, these are all the causes of familial FIO: MEN2A, B, VHL, NF1, and SDHB succinate dehydrogenase B mutation. Each has some special characteristics. And out of all these FIOs, SDHB mutation has the maximum malignance potential. Coming to the treatment of pheochromocytoma, choice is complete surgical resection. Don't be in hurry for giving this clearance for surgery. Better you prepare the patient, start with alpha blocker, because if you start with beta blocker, there is a chance of unopposed alpha action with hypertensive crisis. And regarding alpha blockade, phenoxybenjamin versus prazosin. So there is no big controversy. Depending on availability of molecule, you can use either of these two. So there are number of observational studies. As such, there is no difference in outcomes. And during perioperative period, 2 expected things like hypertensive crisis and also hypertensive crisis are possible. So better to keep 2 lines. And in non-operable pheochromocytomas, sometimes, like for example, malignant pheo, they may require therapeutic MABG and they require lifelong follow-up. Coming to the Cushing's and hypertension, Cushing's is a well-known cause of secondary hypertension and also secondary hypertension and diabetes. So there are multiple mechanisms for hypertension in Cushing's. Clinical diagnosis is very easy, but final satisfaction is not that easy in Cushing. And mechanisms being increased sensitivity to vasoconstrictors. And just now I explained apparent mineralocorticoid excess because of relative 11 beta HSD deficiency situation in the kidney, and insulin resistance, too much production of angiotensinogen from the liver, and ACTH mediated increase in production of deoxycorticosterone acetode. These are the main mechanism. Unlike endogenous hypercortisolism, exogenous Cushing, we don't see hypertension. The low prevalence is due to that exogenous corticoids are mainly of glucose rather than mineralocorticoid activity. And spironolactone is the drug of choice for hypertension in patients with Cushing syndrome. Coming to the thyroid and hypertension, there is a strong link between CV dynamics and thyroid hormone. Both hypo and hyper can cause hypertension. Hypo usually diastolic hypertension, And hyperthyroidism or thyrotoxicosis causes systolic hypertension with wide pulse pressure. And there is one more entity called pulmonary hypertension. In addition to systemic, you have pulmonary hypertension in thyrotoxicosis. Of course, it is not specific to thyrotoxicosis. Any hyperdynamic circulation because of anemia, beriberi can cause reversible pulmonary hypertension. Coming to the hyperparathyroidism and hypertension, both primary and tertiary hyperparathyroidism can cause hypertension, but exact mechanisms are not known. These are the proposed mechanisms. PTH excess activates the ROS pathway, that too much production of aldosterone can in turn stimulates PTH secretion, and both PTH and aldosterone in turn causes arterial wall damage. And for both primary and tertiary, surgery is the treatment of choice. And sometimes even secondary hyperparathyroidism can cause hypertension. Coming to the acromegaly and hypertension, hypertension is seen in about 50% of patients with acromegaly. Like Cushing, acromegaly can cause hypertension, secondary hypertension, and secondary diabetes. Mechanisms are ECF volume expansion, insulin resistance, and production of digitalis-like substances, and altered sympathetic activity. And as expected, acromegaly patients will have, most of the patients, they will have obstructive sleep apnea that also will aggravate hypertension. So to conclude my talk, endocrine disorders are common causes of secondary hypertension, common being the primary aldosteronism. Look for minimal clue and provide a maximal benefit with adequate management. Thank you.
Thank you, Sudhankar, for that excellent in-time talk, which you are known for. I am quite naive and I'm not clear whether we'll get some questions in the chat box, but I'll just pose a question to you that what are your stray thoughts about screening for aldosteronism versus mineralocorticoid receptor antagonist therapy placed in patients with hypertension, essential hypertension, common garden, because many people feel that about 10% of people who are labeled essential hypertension are actually having mineralocorticoid excess. So screening versus therapy, assuming that these people would be treated, given that aldosterone has got vascular problems beyond hypertension.
Yes, sir. Actually, hyperaldosteronism is basically underdiagnosed and underscreened entity, and 10 to 15% of so-called essential hypertensions will be of hyperaldosteronism conditions. But if patient is willing for further interventions like AVA sampling and surgery, then only better to proceed. Otherwise, straight away we can start mineralocorticoid receptor antagonists.
Do you think that mineralocorticoid receptor antagonists are being underused?
Yes, sir. Yes, sir. So basically, even most of the times cardiologists, when they say hypokalemia, just like that, they will try to adjust the diuretic, but they will never refer or they will never evaluate for secondary hypertension.
I think you raised a very important point. Just like the thiazide-induced hypercalcemia, thyroid-induced hypokalemia also needs to be pursued. And many times you might find that the cause is not the drug, but something else.
Yes, sir. Subclinical. It is like a subclinical disease.
Sudhakar, if the patient comes with, because nowadays we are seeing a lot of young hypertension coming to us, and also most of the time when they present, they have their EGFR decrease or their creatinine is increased. So whether the protocol changes or what should we do, the reference ranges, how to interpret the values, the aldosterone, plasma renin concentration, or in the with the renal failure, what is the cutoff for these metanephrines, etc.
So especially with the background of CKD, established CKD, interpretation of that biochemical parameters is not that easy. So very difficult to screen and comment on that biochemical parameters. Once you see the established CKD, very difficult to comment on biochemical parameters.
But I think,
one more small question and comment is your opinion about the antihypertensive use in background before screening for primary hyperaldosteronism.
Yes.
Because previously we used to stop this drug, that drug. Now, do you believe in having to stop antihypertensive therapies of certain kinds?
Yes,
or
sir.
you think that's good enough?
Yes, sir. Actually, medications may cause false negative, but not false positive. So no need to stop medication, especially if renin is suppressed, no need to stop the medication.
So even mineralocorticoid receptor antagonists, some people say if person is having hypokalemia and parameters are favoring aldosteronism, it means that person has got corticoid action. So I think that's a nice point, because many a times when we were young, once upon a time, we used to stop X, Y, Z drugs thinking that they will interfere with the management, but I don't think that is any longer the case. So if there are no comments, thanks for an excellent talk, Sudhakar, as usual. You have raised a very important concern about a prevalent condition, the treatment of which might obviate the requirement for antihypertensive therapies, or at least save the patient from a catastrophic event as happens in pheochromocytoma. But there are certain gray areas. And primary hyperaldosteronism, to what extent to investigate, as you have said already, and what might be the difference in treatment with mineralocorticoid receptor agonists in the absence of a demonstrable tumor. Those are some of the things which are not yet resolved, but you have told about common conditions, uncommon conditions, when to suspect. And it also means that every individual who is quote unquote young need not be subjected to a lot of details. Many people have started investigating people at the age of 40, 35, because the parameters of youngness increases with your age. I think that 60-year people are also young, but the strict criteria have to be there for the age and resistant hypertension, multiple drug therapies, and paroxysm and associated endocrinopathies before you go full-fledged, because the criteria are very strict for diagnosis and the investigations are really expensive. One has to keep their eyes open. And I remember the founder, Santosh, having diagnosed and discussed a hypokalemia patient as primary hyperaldo many years ago when he joined Apollo Hospital. So we have to keep our eyes open for frank cases, knowing very fully well that a significant proportion of primary aldos will not be diagnosed and they would be treated just like essential hypertension. Calling for greater use of mineralocorticoids, just like we use diuretics before classifying resistant hypertension. I think if somebody is not responding, one might use mineralocorticoid therapies, and one should be careful in using drugs like spironolactone, because in men that can produce gynecomastia, and you should use ipranolone. And also in women, menstrual disturbances can occur with the spironolactone. Again, ipranolone is good. I would hand over the proceedings to the organizer. Thank you very much. And I also request my co-chairperson to give any remarks if he might have.
Dr. Arun?
He's muted. Dr. Arun, are you there?
Yeah, I think he's muted. He's. But Arun, you're muted, sir. Please unmute yourself.
Okay, I think there is some technical problem.
We can go to the next.
Yes. Thank you very much, the chairpersons and speakers, for the wonderful session. Before going to the next session, I like to remind the audience delegates that next week, February 14th, also we are having the session. So please do join on that day also. So for further sessions, I request Sudhakar Reddy to do this one, take the further proceedings.
Yes. So we'll move on to the next session. To chair this session, we have two eminent faculties, Dr. Manohar and Dr. Ram Mohan. And Dr. Manohar He has a triple FRCP degree from Edinburgh, Glasgow, and London, and is a recipient of number of awards, and including Kampagoda Award, that is the highest civilian award for Bangalore by BBMP in 2018. Right now, he is consultant physician and diabetologist at Sharda Medical Center and Manipal Hospital, and the medical director of GT Foundation and author of number of chapters in various books. And next, Dr. Ramohan, my good friend from Nellore. To his credit, he has 2 gold medals in MBBS and is member of ADA, IDF, and AACE, and teaching faculty at Narayana Medical College. Right now, he is consultant at Apollo Specialty Hospitals, Nellore. Welcome, Dr. Manohar and Ramohan, and Dr. Manohar will introduce the first speaker.
Thank you, Magna Code. Thanks to my good friend, Dr. Anant Raman and Dr. Sudhakar Reddy. Nice to have my friend Rama Mohan around with me. So we'll move on to the topic. Before the topic, introduction of the speaker, we have an eminent speaker from Chennai, Dr. G. Shanmugha. He is an endocrinologist trained from PGH Chandigarh. He has numerous publications in prestigious journals. Best outgoing student in MBBS, and who has topped in many of the subjects during MBBS, and he has also received A.V. Gandhi Award for Excellence in Endocrinology, best clinical acumen in spot cases, and he will be talking about an important topic on hypercalcemia. I think it's one of the most important, this electrolytemia. We always look at sodium, potassium, but calcium, sometimes yes, sometimes no. Most of it we attribute to hyperparathyroidism or malignancy. Just to set the tone for the talk, the symptoms are not just based on the value of the calcium, but how fast it has gone up or gone down is important. So over to our eminent speaker, Dr. G. Shanmugha.
Thanks, Dr. Manohar. Good afternoon to everyone, and thanks everyone for joining this meeting. So as Dr. Manohar said, most of the times in the hypercalcemia, it will be asymptomatic, and the most important thing is the degree of hypercalcemia and how fast it's rising. That's very pertinent point he has told. So what I'm going to do in my next 20 minutes is briefly discuss about the calcium metabolism. So what are the symptoms the patient can present with, and what are the common causes for hypercalcemia? And mainly I'll be focusing on how to approach. So how to approach to the diagnosis of what is the etiology for the hypercalcemia, and also briefly discuss about the treatment for hypercalcemia. Calcium homeostasis, most of us must be aware about this, because this has been taught from even from the first year of MBBS about the calcium metabolism. So mainly there are 3 hormones regulates the calcium. One is the parathyroid hormone, second is the calcitonin, third is the active vitamin D. So whenever the blood calcium level goes down, the parathyroid hormone is secreted, which stimulates the calcium release from the bone and also increases the reabsorption of calcium in the kidney and activates the active vitamin D, 25-hydroxy 125 dihydroxy vitamin D. So all this leads to increase in the blood calcium level. So the calcium homeostasis is maintained. Whenever the calcium levels goes down, goes high, then calcitonin is released, which stimulates calcium deposition in bones and reduces the calcium uptake in the kidney. So just the opposite of the PTH, except that it doesn't act at the level of vitamin D activation. So almost the opposite action of the parathyroid hormone. So these 3 hormones acts together to maintain the calcium level in the normal range. So basically the PTH acts on the bone and acts at the kidney to increase the calcium level, and indirectly influences the gut absorption via activating the vitamin D. And vitamin D has action only on the gut. It increases the calcium and phosphorus absorption, no direct action on the bone or the kidney. And calcitonin is just opposite to the PTH, inhibits osteoclast and inhibits the calcium, increases the calcium excretion, and it doesn't have the direct effect on the gut. This is in brief. And coming to in the clinical practice, always when the patient comes to the value, we should see whether it's a fully hypercalcemia or pseudo hypercalcemia, because the albumin is attached to the calcium. Almost 45 to 50% of the calcium is attached to the albumin. So we should look for the albumin status, because many times volume depletion or multiple myeloma or high albumin status can lead to pseudo hypercalcemia. So we have to do the correction, and many times low albumin status also will affect the serum calcium level. So we have to see the corrected calcium level, which is serum calcium plus 0.8 into normal albumin minus patient albumin. So always when the patient comes to some abnormality in the calcium level, either hypo or hypercalcemia, always look for the corrected calcium level. But in certain situation, like in severe acidosis or alkalosis, many times the total calcium may be normal, but there can be abnormality in the ionized calcium. So in those cases, better to measure ionized calcium, because usually in alkalosis there will be hypocalcemia, in acidosis there will be hypercalcemia. So always better to measure ionized calcium in this clinical situation. Okay, what are the symptoms of hypercalcemia? As already told, many of the times the patient will not have any symptoms, particularly if the calcium levels in the mild hypercalcemia or moderate hypercalcemia. So less than 12 we say as mild hypercalcemia, and 12 to 14 moderate, and anything more than 14 it's called a severe hypercalcemia. So usually up to 14, most of the patient may not have any symptoms. They may have a very non-specific symptoms like lethargy, polyuria, etc. But the most important is the degree of rise in the calcium. If there is sudden rise in calcium, the patient may have symptoms even in moderate hypercalcemia. So usually the patients will present with like a polyuria, polydipsia, and nausea, vomiting, and the change in sensorium if there is a sudden rise in calcium levels, or if they have severe hypercalcemia. So we should look for calcium level if the patient presents with these symptoms. Otherwise, most of the times the patient presents with only the biochemical values. And what are the typical symptoms? This is a standard terminology, that is the bones, stones, moans, and groans. So the patient presents with either the renal symptoms or skeletal or GI or CNS symptoms. So the most common renal symptoms are polyuria, and prolonged hypercalcemia can lead to renal insufficiency, renal stones, and nephrogenic diabetes insipidus also. And GI, they can present with nausea, anorexia, constipation, and again severe hypercalcemia can lead to pancreatitis also. And hyperpara can lead to osteoporosis, and increase in the PTH level can lead to formation of osteitis, fibrosis cystica. And as already told, sudden rise in calcium levels or severe hypercalcemia can lead to altered in sensorium, confusion, even sometimes coma. So those are emergency condition where the calcium level has to be brought down very fast. And calcium also increases the myocardial contractility and irritability. So in the ECG, they can have prolonged PR and shortened QT interval and widen QRS complexes. And prolonged hypercalcemia can lead to calcium deposition in coronary arteries and myocardial fibers also. So they are more prone for cardiac disease also. And high calcium level again is associated with hypertension. This is very well known association. So what are the common causes of hypercalcemia? So if based on the underlying mechanism, we can classify hypercalcemia due to increased bone resorption or increase in the calcium absorption. The increased bone resorption is mainly due to the increase in the PTH level. So it mainly happens in primary hyperparathyroidism and secondary and tertiary hyperparathyroidism. Again, hypercalcemia due to malignancy can be due to various reasons, like humoral hypercalcemia, where the PTH related protein is elevated, which leads to bone resorption, or even the local tumor osteolysis can lead to hypercalcemia, or increase in the inflammatory marker like interleukin 6 and tumor necrosis factor alpha also can lead to increase in the bone resorption. So it leads to the hypercalcemia. And other conditions like thyrotoxicosis, immobilization, and hypervitaminosis A also causes hypercalcemia due to increase in the bone resorption. And calcium absorption increases mainly due to the increase in the intake of the active vitamin D, which usually many times has been inadvertently prescribed in many times by the physicians, or many times in CKD, if we give very high dose of active vitamin D, that can lead to increase in the calcium absorption, hypercalcemia. Milk alkali syndrome, where the patient takes a lot of calcium carbonate, mainly in the form of powder, where they take unlimited quantity of calcium carbonate, that can lead to milk alkali syndrome. Hypervitaminosis D, increase mostly injectable, if the patient gets injectable vitamin D, that can lead to hypervitaminosis D and increase in the calcium absorption, so hypercalcemia. But most commonly what we do in our clinical practice, particularly to diagnose what is the etiology for hypercalcemia, we classify based on the PTH level. So whether it is a parathyroid mediator or non-parathyroid mediator. So that makes easy for us to classify and also plan for the treatment. So parathyroid mediated, most common cause is PHPT, that is a primary hyperparathyroidism. Almost 60 to 70% of the causes by the primary hyperparathyroidism. And rarely the close differential diagnosis is familial hypocalciuric hypercalcemia. I'll be discussing in the next few slides how to differentiate PHPT from familial hypocalciuria hypercalcemia. Again, PHPT may be associated with various symptoms also, like men, or it can be familial isolated hyperparathyroidism also. And tertiary hyperparathyroidism in CKD also can lead to PTH-related hypercalcemia. And rarely, malignancy secreting PTH, ectopic PTH secretion can be there, which again can lead to PTH-mediated hypercalcemia. So non-parathyroid mediated hypercalcemia is mostly due to the malignancy. So it may be, as I already told, it may be due to humoral malignancy, that is due to a PTH-RP secretion, or increased calcitriol, activation of the extrarenal 1-alpha hydroxylase, which happens in lymphoma, leukemia, etc., or local bone osteolysis and local cytokines production again can lead to a non-parathyroid mediated hypercalcemia. Other common causes are vitamin D intoxication and increase in the 1-alpha hydroxylase in the granulomatous disorders like sarcoidosis. And medications like thiazide, lithium again can lead to non-parathyroid mediated hypercalcemia. Other endocrine causes, acromegaly, pheochromocytoma, adrenal insufficiency again lead to non-parathyroid mediated hypercalcemia. How to approach a patient with hypercalcemia? So when patient present to us with the high calcium readings, the most important thing is we should look for some clinical clues. Mostly in PHPT, the patient will be asymptomatic. They will just present with the biochemical finding with some mastral checkup showing high calcium levels. And postmenopausal women are more prone for PHPT, and usually they don't have any clinical findings. And there will be no other obvious cause of hypercalcemia, like example lymphoma, sarcoidosis, etc. And rarely there can be a family history of hyperparathyroidism. And if there is evidence of other endocrine disorder, then we should suspect multiple endocrine neoplasia. In hypercalcemia of malignancy, usually there will be severe hypercalcemia and there will be rapid increase in serum calcium. And usually the disease will be in the advanced stage and they will be cachetic. So it's reasonably easy to make a diagnosis, because usually in PHPT, unless it's a very long-standing PHPT, the patient presents with CKD, usually they will be very well preserved. Whereas in hypercalcemia of malignancy, they will be more cachetic. Already the diagnosis of malignancy would have been made. And also very important is we should review the medications and diet, both the prescribed and non-prescribed, because many times they may be taking some other Ayurvedic medication or non-allopathic medication, some herbal preparations, etc., which may be containing calcium and vitamin supplementation. And because milk alkali syndrome model, if you see, they must be taking the calcium carbonate powder in huge quantity. And so that's very, very important. We should ask for the diet history and medication history. And also we should ask for history like drugs like vitamin A, lithium, thiazides, etc., because again, those things can lead to hypercalcemia. Lab clues, as already discussed, the most of the times hypercalcemia is classified as either PTH or non-PTH mediated. So if PTH is more normal, then we should look for PTH-RP and vitamin D metabolites, 25-hydroxy and 125-hydroxy vitamin D metabolites. If that is also normal, then we should do the workup for myeloma, hyperthyroidism, and vitamin A intoxications. We'll go through 3 cases. So the first case is 45-year-old male, noted to a mild elevation in serum calcium and routine testing. Last 2 times, the calcium is between 10.5 to 10.7 milligram per deciliter, corrected calcium. Is asymptomatic. So when we do other lab parameters, his PTH is elevated, vitamin D is normal. Again, very important, most of the times the most common cause of increased PTH is vitamin D deficiency. So we should correct vitamin D deficiency always. But if patient has vitamin D deficiency along with high calcium, then always we should rule out primary hyperparathyroidism, because usually with vitamin D deficiency, there should be low calcium. So if the patient has high calcium with borderline high calcium with vitamin D deficiency and high PTH, we should correct vitamin D, but at the same time, we should rule out hyperpara also, because creatinine is normal. So what is the most likely diagnosis? And medication history, then do PTH. In this case, we have high PTH. So we should look for PTH-related hypercalcemia causes. As I already told, the most common cause of PTH-mediated hypercalcemia is primary hyperparathyroidism. So with increase in calcium, always there will be increase in the PTH level. And if you see hypercalcemia of malignancy, the PTH level will be significantly decreased. Usually it will be less than 20. So the most likely diagnosis in this case is primary hyperpara. And the second most close differential diagnosis is familial hypercalcemia. Again, the PTH will be mostly normal or mildly elevated in FHH. Whereas in PHPT, it will be upper normal or more elevated. So in this case, most likely it will be primary hyperparathyroidism. So this is most common cause of hypercalcemia in the outpatient setting. And renal calculi may not be seen in all the cases. Maybe in 20% of the cases, renal calculi may be seen. And again, the classic bone disease also rarely seen. Unless the patient is having long-standing disease, they may present with this fractures, osteoporosis, or brown tumors, etc. And these patients are prone for vertebral fractures. And the most common or close differential diagnosis is familial hypocalciuric hypercalcemia. So it's autosomal dominant condition caused by inactivating disorders of calcium sensing receptor. And usually PTH will be normal and they will have mild hypercalcemia. So how we have to diagnose this? We have to measure the urinary calcium excretion. Usually the calcium creatinine clearance is less than 0.01. It's typical with the familial hypocalciuric calcemia. So this is how we differentiate. In PHPT, the urinary calcium excretion will be more, the calcium creatinine clearance will be more, whereas in the familial hypocalcemic calcemia, it will be generally low, and the PTH will be normal or mildly elevated. This is how we have to differentiate PHPT from familial hypocalcemic hypercalcemia. Again, the most common thing in our setting is PHPT with vitamin D deficiency. In this condition also, there can be lower urinary calcium, but usually the PTH will be elevated. Always supplement with vitamin D and repeat the parameters. So the urinary calcium will be increased once we supplement with the vitamin D. Case 2, the known 70-year-old female, known case of renal cell carcinoma. Now recently the calcium levels has been noted to be around 13.4. So the lab parameter shows low PTH and low phosphorus, and vitamin D is normal, and PTH-RP is elevated. So basically, we have ruled out it's not PTH-related hypercalcemia. So the more common or the most likely etiology in this case is PTH-RP related. That is humoral hypercalcemia, malignancy-related hypercalcemia. Usually, humoral hypercalcemia of malignancy, usually they have already diagnosed malignant disease, and this is one of the most common cause for inpatient hypercalcemia, because most of these patients will have severe hypercalcemia and they usually present with symptoms. So this is the very common cause for inpatient hypercalcemia. So they will have low PTH and increase in the PTH-RP elevated. So there are many malignancy which can associate with hypercalcemia, and also many mechanisms with which it can cause hypercalcemia. So humoral hypercalcemia is due to increase in the PTH-RP. So most of this squamous cell carcinoma, renal bladder carcinoma causes the hypercalcemia via this mechanism. And local osteolytic metalysis due to breast carcinoma, lymphoma, leukemia, multiple myeloma can also cause hypercalcemia. And conditions like lymphoma, which has extrarenal 1-alpha hydroxylase activity, can lead to hypercalcemia via increase in the 125 dihydroxy vitamin D. Ectopic PTH secretion again rarely can happen in some of the cancers, which can lead to mimic PTH-related hypercalcemia. So case 3, a 51-year-old male presents with fatigue and trouble with 5 kg weight loss, and calcium is noted to be around 13 mg per deciliter. Again, his PTH is low, but in X-ray it shows hilar lymphadenopathy and 24-hour calcium is elevated. Vitamin D is normal and creatinine is normal. His dihydroxy, 125 dihydroxy vitamin D is elevated, almost 2 times the normal level. So basically, this is again the PTH-related hypercalcemia is not there, and PTH is low. And in this case, the most likely possibility is the cancers or lymphoma, that is some granulomatous disorders causing the non-PTH-related hypercalcemia. So this is basically due to the granulomatous disease. So most probably sarcoidosis is the most commonly associated with non-PTH-related hypercalcemia. Again, lymphoma also can present with this kind of disease or any other granulomatous disorders also. Basically, when the patient presents with elevated serum calcium, reconfirm the value and also look for corrected calcium. So because many times the altered albumin level can lead to altered calcium levels. Then measure PTH, because we are going to make diagnosis based on this, whether it's a PTH-related or non-PTH-related hypercalcemia. So if PTH is significantly elevated, the most probable diagnosis is primary hyperparathyroidism, and very close differential diagnosis familial hypocalciuremic hypercalcemia. So after correction of vitamin D, if still the urinary calcium is very low, then it's more likely FHH. The urinary calcium is more, then more likely diagnosis PHPT. So do workup for PHPT. And if PTH is normal, then we have to measure PTH-RP and vitamin D metabolites. If PTH-RP is elevated, then diagnosis is humoral hypercalcemia of malignancy. If PTH-RP is normal, then look for vitamin D and 125 hydroxy vitamin D. If 125 hydroxy vitamin D is elevated, then most likely some granulomatous disorders causing hypercalcemia. that is normal, and if 25-hydroxy vitamin D is elevated, then vitamin D intoxication is the more likely possibilities. If all these parameters are normal, then we should look for other causes like hyperparathyroidism, multiple myeloma, or vitamin A intoxication. Coming to treatment briefly, most of the patient may not require treatment because, as already told, they may be having the chronic hypercalcemia. Even the chronic hypercalcemia with symptoms of 12 to 14 can be monitored, and if required, we can start treatment. If the calcium rise is very fast, then we can treat. But more than 14 milligram, any patient, even without asymptomatic, we need to treat. So the aim of treatment is lower the serum calcium concentration and, if possible, treat the underlying cause also. So the basic dictum for all this hypercalcemia treatment is correction of dehydration or volume depletion, correct any other electrolyte abnormalities, discontinue medication that may cause calcium elevation, and reduction of dietary calcium in states of intestinal hyperabsorptions like vitamin D intoxication and milk alkali syndrome. And weight bearing and immobilization is very, very important. And first line of treatment is rehydration. So give isotonic saline at 200 to 300 ml per hour to maintain the urine output around 150 to 200 ml per hour. So the concept of saline diuresis is not followed nowadays because now we have very good anti-resorptive therapies. So unless the patient has cardiac failure or renal failure, no need to use the loop diuretics. We can just rehydrate and start the anti-resorptive therapy. Either start the calcitonin, injectable calcitonin, but it's very difficult to get in India. So give nasal calcitonin. It's a very less effective drug, but if patient responds to that, continue that drug. Otherwise, stop the calcitonin, but always start the anti-resorptive therapy. So start bisphosphonate, preferably injectable bisphosphonate like zoledronate, so which has onset of action within 24 to 72 hours. The patient has contraindication for bisphosphonate like renal failure, then denosumab may be used. But the problem with denosumab is the patient is more prone for hypocalcemia. So we should be very careful with denosumab, always monitor for hypocalcemia after treatment. And steroids are indicated if there is an increase in 125-dihydroxy vitamin D or vitamin D intoxication, then steroids can be started. And calcium mimetics like cinacalcet can be used in parathyroid carcinoma or secondary hyperparathyroidism or tertiary hyperparathyroidism. And if the patient is not responding and it's a very severe hypercalcemia and the calcium levels are more than 18, then we can go for dialysis with no calcium dialysate. The disease-specific approach, so PHPT, the most preferable treatment is surgery. And if patient is not willing for surgery or not fit for surgery, then maybe cinacalcet and bisphosphonate for associated osteoporosis. And many times, if it's asymptomatic or normal calcemic PHPT, we can do observation also. So parathyroid carcinoma, the first choice is surgery. If surgery is not possible, then maybe we can put the patient on cinacalcet with bisphosphonate or denosumab. Familial hypocalcemic hypercalcemia, no treatment. Lymphoma, other granulomatous disorders, low calcium diet plus steroids and treatment of the underlying disorders. Vitamin D toxicity, steroids plus bisphosphonate. So asymptomatic hyperpara, treat if calcium level is 1 milligram per deciliter more than the normal rate and the patient has already has some fragility fracture or the patient has osteoporosis, and if creatinine clearance is decreased and 24 urine calcium is more than 400 milligram per deciliter, or there is already presence of renal stones and age is less than 50, we can subject the patient for surgery. Otherwise, we can just monitor the patient annually. If the patient is developing any of these parameters, then we can subject the patient for surgery. So to conclude, the most common cause of hypercalcemia in the outpatient setting is primary hyperparathyroidism. Most of the time, they will not have any symptoms. Only in long-standing hyperparathyroidism, they can present with pancreatitis, renal failure, or fractures, or osteoitis, fibrosis, cystic, etc. And most common cause of hypercalcemia in inpatient setting is malignancy. So treatment, the most important thing is bring down the calcium as fast as possible with the available therapy. The most important therapy is rehydration plus anti-resorptive therapy. Along with that, we have to look for the cause for the hypercalcemia, and we have to do the disease-based approach also. With that, I conclude. Thank you.
Excellent talk. Thank you for that, Dr. Shanmugha. Over to Dr. Rama Mohan.
So, fantastic, Shanmugha sir. It's indeed a very lucid presentation, and we generally very much confused with the hypercalcemia during general OPD and OPD practice. We tend to miss many mild cases of hypercalcemia or maybe like parathyroid adenomas like that. So this flowchart diagram will be especially helpful for all the practitioners to go about hypercalcemia. So thank you so much, sir. Do you have any questions now, sir, after second session, sir?
After second session.
Yeah. Thank you. So Krishna, sir. Yeah.
Just a minute, I'll share the.
Yeah, Krishna,
slide.
sir. Yes, sir.
Just a minute.
Yeah, it's indeed a pleasure to introduce Dr. Krishna Shankar, MD, DM, MRCP, endocrinologist at Sri Ramakrishna Hospital. To be one of my best friends, and I'm very happy to share his CV here. And he has credentials of 6 peer-reviewed publications and international and national publications. Offbeat, he is a best person or a great personality to be friend with, and I welcome him to Magna Code to present his presentation. Thank you, Dr. Krishna.
Thank you, Dr. Ram Mohan. Indeed, I appreciate your comments, and I'm thankful to you, as well as I thank Magna Code and the organizers for this excellent conference, up to date about endo and diabetes. Well,
it's indeed inspirational, and to have Magna team and to be part of Magna is now become a trademark. Like it's like a Rolls Royce of endocrinology.
Exactly, sir. Are the slides visible?
No, you can share.
No,
just a minute.
First open the PPT, then press the share screen.
Open your presentation first. Then go back to Zoom and click on share screen and select the presentation.
Krishna will be speaking about remogliflozin, and we know that SGLT2 inhibitors became a best second line agents. They climbed up the ladder of second line agents with good scientific background, and most of our patients coming to our OPDs will be segregating them depending on their risk factors, like having a CVA or what's the cardiovascular disease risks. So that yeah, sure.
Can be shared from the
Mintu, he has shared the slide to the mail ID. Can you share that one?
Yeah.
Let me just check my email once. Oh, so I don't have his presentation.
Oh, this email, gmtech@expocongroup.com.
Yes. That is on the other hall.
Yeah. In the meantime, Shanmugh sir or Manoj sir, you can share your experiences with SGLT2 inhibitors and remogliflozin, like 1 or 2 minutes. You can, sir. Manoj sir.
I think the SGLT2 inhibitors, as we all know, are a blockbuster molecules. Let alone second line agent. Even I think in certain conditions, they are even talked of as the first line agents if atherosclerotic cardiovascular disease and renal disease are of prime concern for us. I think he's ready, and he will enlighten us more about it. And the cost effectiveness is definitely a highlight of this molecule.
Yeah, thank you, sir. And Krishna, you can go ahead with your presentation.
Yes, sir. So thank you, sir, and sorry for the delay. So, I'm not going to present something new, but I'm going to refresh and about the new molecule, which is making noise amidst even more noise made by the SGLT inhibitors for the past decade. That is remogliflozin. Is it refining our practice in the already existing newcomer SGLT inhibitor armamentarium? It is even more, it's something like a fine tuning. Is it going to do? So this is a picture or a painting given by Kuhn, a German philosopher, a German writer. This is the paradigm effect or the paradigm shift, which we are using that word much more common in the past 5 years, particularly in endocrinology presentations, diabetes presentations. So how we approach a problem and how our thought process constantly shifts for our convenience or for the general well-being. So this picture can be a bird or a rabbit. So a paradigm shift is defined as an important change that happens when the usual way of thought process about doing is replaced by a new and different way. So, well, so all through the years, all through centuries together, the wheel was developed by man, whereas conventionally we think cost effectiveness or whatever, when we sit and plan a work, we think that is not the conventional way. We have to follow the routine past pathway which others have put. Will that be useful or not? We don't assess. So now times have changed. We have started thinking that various other pathways are there in our management, particularly in diabetes mellitus. So the routine science over the past few years, particularly the past century, was treat everything via the beta cell. So then later came external research. Is there any other pathway? And then, yes, indeed, of course, not just the beta cell or the just not even the adipose tissue, not even the liver. Yes, there is a new paradigm. There is a new pathway via the kidney. Particularly over the past 20 to 30 years, it has been developed. And aftermath of this revolution is there is indeed an insulin independent pathway to control glucose, not just glucose control, and also protect the heart. So that is eventually you have to save the patient, protect the heart. That is the ultimate goal in treating diabetes mellitus. So that too not in type 2 diabetes, also in type 1 diabetes. So what are the challenges in management of type 2 diabetes, even type 1 diabetes? Most important is cost. So just now, Dr. Manohar said just cost being the most important factor in our nation, particularly amidst this COVID-19 pandemic economic crisis hitting the nation hard for the past 14 months or so. So cost being the major challenge. Now it is not uncommon for the past few months that we are seeing patients who are just saying we are not able even to afford insulin, a life-saving drug. Forget analogs, even regular insulin, NPH insulin, many people are not able to afford. So we need drugs which are indeed cost effective and still equally effective than all other developed drugs. So mistrust in drugs and side effects, we have to address. The next common is myths in India. We have to address all those things and existing micro and macrovascular complications, not just to prevent. We have to address our prescriptions based on those complications, not to cause further harm. And other comorbidities, cardiac, neurology, rheumatology, bone issues, cancer issues. We cannot keep on prescribing metformin in a patient with a colon cancer or a GA cancer, having even more diarrhea or GA symptoms. Active infection, so liver and renal pathology, hypoglycemia and weight gain, another important factor. Now there is a tendency for over treatment for glucose, so that precipitates hypoglycemia and weight gain. And most important is patient compliance, again cost being the factor. So objectives, so we will be overlapping the objectives. So SGLT inhibitors. So now we have discussed about what we are discussing about the novel molecule SGLT inhibitors. Amidst that there is remogliflozin. So before that there was a search for a potent selective SGLT inhibitor. It was developed from apple trees about 30 to 40 years back. So they found that the florezin from the bark of the apple tree, when utilized in rats as a research molecule, so reduced the glycemic hyperglycemia and improved the insulin sensitivity. Even by way of hours in partially pancreatomized rats. So that made a basis of development of SGLT2 inhibitors as a therapeutic agent, as a non-beta cell pathway therapeutic agent for diabetes mellitus. So to make a long story short, various gliflozin has been developed for the past 10 years, particularly past decade, amidst the so many CE of CVOT trials. We have proven that indeed flozins are safe and efficacious, and extremely efficacious, even having a superiority effect. So a mild change of the biochemical chains with the O glucoside as well as C glucoside, scientists were able to develop various different molecules. So remogliflozin as well as canagliflozin, dapagliflozin, empagliflozin. So all these are 4 flozins which are available in India. So for past 1 decade, almost 5 or 7 years, various flozins have been developed. Disclaimer: this is not about any specific manufacturing company. There's just development, which are the primary developers of all these molecules. So remogliflozin indeed is a good choice of Indian type 2 diabetes mellitus patients amidst the existing efficacious proven SGLT inhibitors. All are good. There's no question about it. All are safe. All are very well established by massive mammoth excellent grade A recommending trials. All the flozins, SGLT inhibitors. So how about the newcomer, the new kid in the block, remogliflozin? Is it a good choice? Yes, indeed, it's a good choice from the existing evidence and also from a small personal usage. So it's a small chemical analysis. Is a remogliflozin etopenate is purely theoretical. It's a ester prodrug of remogliflozin. The good thing is it's a very selective inhibitor of renal SGLT2 transporter 2. So whereas coming to safety profile in renal impairment and hepatic impairment, there is no great difference between remogliflozin and the other molecules. If the GFR is less than 45, definitely it has to be discontinued for one basic purpose. It doesn't work. The efficacy comes down, as well as you need not mess up with the nephrons if the GFR is below 45 with a drug which is going to act upon the nephrons. Hepatic impairment, still not very clear. We need a lot of data about the safety and efficacy. Better to stop in moderate to severe disease. We don't want a volume depletion. That holds good for almost all SGLT inhibitors. There is no specific extra added benefit nor extra harm in remogliflozin when compared to other SGLT inhibitors. So this indeed was the one good phase 3 trial. The numbers were good, almost like 1,838, and were randomized and were followed up in a pretty long period of time, initially for the efficacy and safety. Of course, you need even more larger randomized control trials, something like in the order of the samples of 3,000 over a long 3 years, a good CVT trial. That is indeed a good scope for research for remogliflozin in India, particularly because of the cost effectiveness as well as the increased awareness. Now this is a very good scope for research, active research at all levels, tertiary care center, teaching center, where we can take up the efficacy of remogliflozin safety and address over a long period of time. So this phase 3 trial, as compared to a standard use dapagliflozin 10 milligram, so has been shown to be efficacious as well as safe. So I'm not going deep into the trial, but one thing is for sure, it has been shown efficacious as well as non-inferior. Safety has been good. There is no added threatening side effects, extra threatening side effects when compared to dapagliflozin. So, well, particularly in 2019 and 2020, completely digitalized ADA, there has been good case reports and e-posters from the Indian side about remogliflozin, as well as comparison with another good molecule, canagliflozin, as add-on therapy for the efficacy and safety. All the numbers are not huge, but it's anyway. So what I'm trying to project is that indeed there is a good amount of volume of studies going on, as individually as well as a team from doctor's side as well as the researcher's side. So this is another study showing the relation in progression of nephropathy, although in a short period of span of time. So again, real world studies, these are posters which are posters and which has been presented in ADA 2019 and 20. So how about the most important point, affordability for the commoner? So that is the ultimate issue in case of diabetes management in a country with around 7 crores to 8 crores of type 2 diabetes mellitus estimated, which is still increasing day by day. And it is not rare for us seeing patients with type 2 diabetes at the age of 27, 23, 19, with a BMI of 33, 37. It's becoming extremely common. So affordability has to be an important factor, because they are going to remain as diabetes for a long period of time, and their expenditure for diabetes medications is going to increase. So they will be expecting a reasonably better option, which has got all the pleiotropic benefits as well as less cost. So indeed, it's a good choice for Indian diabetes mellitus patients, affordable for the common man, simply because of the existing maximum retail price available in the market. So when on comparison, the efficacy is good in case of remigliflozin. Personally, I have used a few patients. Of course, all the senior colleagues here, I hope all have started using it and have appreciated the difference, the cost effectiveness particularly when compared to the other molecules. So this is mechanisms of SGLT inhibitors holds good same for remagliflozin also, same natriuresis, glycosuria. Apart from glycosuria, uricosuriya, and reduction of triglycerides also, preload, afterload, and reduction in insulin resistance. So adverse events again almost the same, but what I sometimes appreciate is when we use the remagliflozin, usual dose is 100 milligram BD. Sometimes you may even use one in the lunch also rather than the night to avoid excessive polyuria in the night. We can sometimes use one in the, we can personalize one in the lunch, one in the breakfast rather than the night. Sometimes we use like that. And the adverse events, what I appreciate is when we use OD dose for just mild hyperglycemia in the breakfast, the side effect profile is quite less when compared to BD usage. So that is one advantage of this drug, where we can, there is a flexibility for using OD dose, sometimes even a half tablet. So there is a flexibility to avoid side effects as well as to cut down the cost. So are we shifting for better? So this is a good paradigm shift. Yes, just a few cases, if there is time, a few cases. So he is a 60-year-old breadwinner with a HbA1c of 17. So now again, it is not uncommon for endos to see a HbA1c of 17, 18 hovering around, coming to the OPD also. So not just getting admitted in the ICU or in the critical care. It is becoming extremely common. It means 15, 16 patients with type 2 diabetes mellitus. I wonder whether it was previously so common. Just now the modern assays are picking up very high HbA1c levels. So this patient had high random blood sugars too. So he was put on mix 50 insulin TDS. BD was not sufficient. TDS. He didn't agree for basal bolus of 4 times plus metformin. Patient was stable. So in 1 month, sugars were controlled, and he was requesting that I will be able to give insulin only once in the morning. Well, upon adding so many insulin sensitizers, if you add pioglitazone, which is again an excellent molecule, now coming back. So this patient was changed into just one shot of insulin per day in the morning, and again cost effectiveness. He was a breadwinner. He was economically he was downtrodden, and he wanted drugs which are extremely cost effective. So previously, maybe 5 to 10 years back, we had the options of DPP-4 inhibitors and SGLT inhibitors, which are definitely expensive on any range of Indian economy. We need at least 100 rupees per day, I think so. If you add a full dose of a DPP-4 inhibitor plus a full dose of a SGLT inhibitor, you need at least 100 to 120 rupees per day. But now we have the advantage in our hand. We can have the effect of a reasonable gliptin, like a teneligliptin, plus remagliflozin, cutting down the cost to even 20 to 30 rupees per day, from 100 rupees to 20 rupees per day. So in this patient, if you see just one shot of insulin, as time passes, we may even stop that insulin, and we were able to put fully on insulin sensitizers and bring down the glucose and maintain the stability. So this patient, again, HbA1c of 12, premix 30/70 twice daily with recurrent hypoglycemias. He was started on basal bolus, again not willing for 4 pricks. This is the issue with basal bolus. Although that is the eventual standard of care, basal bolus or basal plus insulin, patients are resistant or not willing for 4 pricks. So this individual, if you see, he was requiring tons of insulin. So to bring down the HbA1c, to bring down to standard levels, so he required lots of insulin, split mix insulin, almost like 100 units per day, 120 units per day. So the good thing was he started developing hypoglycemias, even on slow titration, this patient. So we were, upon adding SGLT inhibitors, remogliflozin was added again for cost effectiveness. They were not affordable for other SGLT inhibitors. They were not affordable for 60 to 70 rupees per day for a single tablet. So putting on remogliflozin as well as other gliptins, metformin, and other insulin sensitizers. So this patient was able to, we were able to bring out of insulin. It's not just that all patients, OAD failure is gone are those days where before 2010 we were able to say OAD failure, it is a must, we must maintain on insulin based on clinical findings and biochemical findings. Not exactly. Now in the modern era, when you have SGLT inhibitors, even other drugs, insulin sensitizers, we were able to bring patients out of insulin upon adding these agents. So this individual, again, he was on insulin, poor follow-up, arrives with acute coronary syndrome, coronary artery bypass was done, HbA1c was quite high. So this was the previous, almost like a few weeks to few months back, this was his continuous glucose monitoring. So this can be achieved almost near normal with the use of SGLT inhibitors and particularly cost-effective molecules with insulin. This kind of curve can be achieved. So again, this on outpatient basis, how can molecules like remogliflozin can be used on outpatient basis? Again, muscle checkup, which is quite common in tertiary care centers nowadays. For patient came for diabetes, BMI of 37, obese, hypertension, gout in remission, and almost macroproteinuria with a HbA1c of 8.9, glimepiride and metformin. He was on glimepiride and metformin. And he was a hypertensive also. He had defensive eating, frequent hypoglycemic episodes. He had defensive eating, and he was on sitagliptin or put on sitagliptin also plus metformin. Still had mild hypos. So we just added remogliflozin, 100 milligram per day. Initially OD, then BD. That is 200 milligram per day. So we were able to withhold the glimepiride and stop defensive eating and stop the hypoglycemias also. So why particularly just for reducing the weight? No, this individual will be an ideal candidate for adding SGLT inhibitors, particularly remogliflozin, simply because he had hyperuricemia, hypertension, obesity, and macroproteinuria. So all these are effective indications for adding SGLT inhibitors. So another individual with morbid obese, 50-year-old female, HbA1c of 9. So she had severe OSA and she was on CPAP, almost like 8 to 12 hours per day. She required CPAP and requiring again tons of insulin because of its severe insulin resistance. So she was on DP4 inhibitor plus metformin. Ideally, she's a good candidate for GLP-1 analog, but she refused simply because of the cost. So we added SGLT inhibitors. That too, she was initially resistant because of the cost. Then we went for remogliflozin BD. Now the insulin requirement has come down drastically, and the one thing we observed was, the CPAP hours were reduced, and the quality of life improved. Her OSA was improved. There was a good appreciation from the pulmonology side also. So this again shows now we are seeing studies where SGLT inhibitors are indeed helping in improvement in obstructive sleep apnea too. So who are not an ideal candidate? Who are not an ideal candidate for SGLT inhibitors as well as remogliflozin? Patients who have active infection. Indeed, we know except gliptins, all other drugs ideally are to be stopped, and only insulin and gliptins may be given in active infection. Any KUB pathology, simply because the drug is going to act via the KUB, kidney urinary bladder tract. So cancer. So ideally, patients who have active cancer better refrain from SGLT inhibitors. It is not an absolute contraindication. It's not even a relative contraindication. So just a personal thought where you don't want a volume depletion or a sudden infection getting precipitated. So atherosclerotic cardiovascular disease with comorbidities like intracranial hemorrhage, seizures, fluctuating blood pressure, patient who are on IV fluids, shock, GA pathology, just stop the SGLT inhibitors. So this is a just a reminder, many times we come across where patients who are earlier started SGLT inhibitors, the drugs will be continuing ongoing in the existing prescription when they are admitted. So better just stop the oral antibiotic medications as well as particularly SGLT inhibitors. So we do not want a volume depletion. We do not want acute kidney injury to worsen. So on peripheral artery disease with gangrene and active foot infection, mild peripheral vascular disease without any gangrene or without infection, we may use SGLT inhibitors. It can be productive too. Whereas on the other side, it can be counterproductive. It can worsen the existing gangrene or foot infection. So better refrain. Who are ideal candidate? Actually, they are almost the common scenario, the common man and woman who walks into the outpatient department in any Indian scenario. Obese individuals who are diabetic, who are trying to do diet. $60, $100 units per day. These are ideal, excellent candidates who will the most from SGLT inhibitors. It's not like other candidates will be given. These are candidates who will benefit the most. I hope many endos see these kind of candidates. Ideally, they'll be referred for refractory diabetes. Most of these patients fit into these criteria. To summarize, it is a novel, remogliflozin is a novel SGLT inhibitor, particularly in the Indian landscape because of the cost. Other things are almost similar to other SGLT inhibitors like canagliflozin, dapagliflozin, empagliflozin. So in the insulin independent mechanism, it makes it a better option. So the existing evidence have shown at least the safety and non-inferiority to the standard SGLT inhibitor molecules. Pleiotropic benefits are seen. So another advantage, what I see is the flexibility in usage. It can be good. We can go till 200 milligram per day. Sometimes even half tablet we have used. There is just to have the potential benefit of a SGLT inhibitor without affecting the patient's pocket nor having a polyuria. So thank you. I conclude here.
Excellent talk, Dr. Krishna Shankar. I can't see any questions in the chat box, but one small experience saying, I think I also have used it in some of the cases of sleep apnea. And then I've seen some reports. It's not just the weight which gives the benefit. I think there is a lot of things which happens in the respiratory pathways where the fat redistribution and so many other hypotheses like how we talk about the CVOT benefits are also overlaid on that. Any other experts have any other opinion? My co-chair can also comment.
Sir, Krishna, I have a question. See, with the tenligliptin going away after vildagliptin off patent, what about the future of remogliflozin after off patent of DAPA?
Okay.
How do you see the future?
So I didn't mention that particularly because I think still there are legal controversial issues not yet fully solved.
It's not about legal. I'm asking about science. See, you have a DAPA with full scientific background, and which is coming to be off-label. So, like tenligliptin, which has maybe the tenligliptin, what say, it is tarnished. It is tarnished after the off-label of Vilda. So, like that, is there? What about the future? How do you see the future of Remo or these drugs which are not having a scientific background after DAPA? This is about science.
Yes. So science, but I think not exactly science. This is tied up with economics also. So how about just a hypothetical question which can be done? How about we come down on the cost on remogliflozin? So what will happen if the remogliflozin cost comes down? So that can be another hypothetical question which can be put about. But if the dapagliflozin issues are solved and the cost really comes down, then it is indeed going to be a and if it is potent, if the diverse market profile of dapagliflozin is going to be really potent when compared to the original molecule, then it is going to be a challenge for remogliflozin.
Sir, your input, sir.
Can I ask a question, Shankar?
Yes, sir, please.
Yeah, see, you think all gliflozins are same? You think there's a big drawback of the ertugliflozin, which did not show any benefit on the CVOD trials. Actually,
Yes,
it's a neutral trial. So I don't think we can quantify our Indian remagliflozin in the status of the other three gliflozins which have really shown the benefit to the world: cardiac output, cardiac failure benefit, CKD benefit. I think when such things are not there with the molecule, and as rightly Rama Mohan said, the price of the competitor is much come down. Almost, I think, 8 rupees we get a dapagliflozin. I think it's going to be much cheaper. I think we have to wait till some CVOD trials and CKD benefits occur with the molecule. I don't know. We can't push this molecule.
Yes, for sure, sir. This data is absolutely not sufficient when compared to the mammoth amount of data available on the public domain for all other three flozins, particularly DAPA, EMPA, and CANA. So this data is almost like nothing. It's compared. So just the introduction of the usage of remagliflozin we are discussing. It is nothing to. We cannot even compare. So we need time. We need time, at least maybe 2 to 3 years.
I think Dr. Rammohan's point is valid. You see, the problem with remagliflozin is its only leg that it stood upon was its cost. And once you take that away, there is nothing that it can compete with. There is no data, there is nothing. The fact that it will improve the congestive heart failure and be nephroprotective, it appears to be a class effect, might be there, but there is simply no data. So take away the cost advantage, and I think remagliflozin has a problem now.
Go down, sir.
So thank you so much, sir. Thank you, Krishna, sir. And once again, thank Magna Code for a wonderful CME. And it is indeed a pleasure to be with all the stalwarts of endocrinology. Thank you so much, Magna. Thank you.
Thank you, everyone. Thank you.
Thank you,
So,
sir. Thank you.
Yes. I would like to thank both the speakers and chairpersons for nice talks and interaction. Now we'll move on to the next session, last session for today. And for chairing this session, we have three eminent faculties. Dr. Lakshmanan is the Director of Multi-Specialty Hospital at Chennai, named Priya Nursing Home, Senior Consultant, Internal Medicine and Diabetology, currently the Scientific Committee Chairman of API, Chennai Chapter, and Lifetime Achievement Award from MGR University 2012 is the recipient of the following orations. Latest one is Amar Sen Oration Award and also Ananta Subramanian Oration Award. And he has published over 46 scientific papers in various journals. He is a regular teaching faculty for PHFI. And next we have Raman Bodula. Raman Bodula, my friend, is good teacher and good clinician. He did all his medical career from all prestigious institutes like NIMS and SGPGI. Right now, he's consultant and head of the department at Yashoda Hospital. And Dr. Sai is my friend. He's associated with the Diabetes Specialty Clinics, Elbit Medical Diagnostics, and currently working at Apollo Sugar Clinics, Banjara Hills. He has undergone training at diabetology from this University of Zagreb, Croatia, and also from CMC Vellore, fellow of Robert Turner Diabetes and Research Training, Oxford University, and EC member National RSSDI 2017 and 19. And he has abstract paper presentations at various conferences, and has been organizing DEAR, that is Diabetes Education Awareness Research activities for physicians, patients, and received fellowship awards from RSSDI. Now we'll have discussion, two topics, two debates by Prasandeep sir and Anant Raman. Each will be of 15 minutes, followed by 15 minutes discussion. Now it is over to Lakshmanan for introducing speaker.
Yeah, I think Dr. Prasandeep is going to present about the sulfonylurea and thiazolidine should be used in the management of diabetic mellitus, irrespective of what the CVOTs say. I think it's going to be very interesting. I'm sure Prasandeep has got a lot of points to debate the audience and the opponent. He's a very seasoned endocrinologist. Dr. Prasandeep has a vast experience of more than 2 decades. And after qualification from the Kanpur He did his MD in the same college and completed DM endocrinology metabolism from Sanjay Gandhi Institute of Medical Sciences in 1999. And Dr. Day has been associated with hospitals like SCARS Research Center in Hyderabad, Sanjay Gandhi PGIMS in Lucknow, and Kanimeni Hospital in Hyderabad. Currently, he is attached to KMS Hospital as a senior consultant endocrinologist at Hyderabad. I think you have a lot of, I've seen you, I heard you, many lectures. The floor is yours to discuss the necessity of sulfonylurea and the thiazide downs despite the COT the periods.
Person, sir, please unmute. Yeah.
I do not like technology, and technology doesn't seem to like me either. I'll just try and share my slides. Tell me whether you can see them. Can you see them?
Yes.
Right. Okay. All right. So thanks, Dr. Lakshman, for that introduction. And thank you, friends, for having me here. In the next 15 minutes or so, I'm going to tell you why, in spite of whatever speaker comes to you and tells you about the newer molecules and how great they are to the heart, kidney, and your neighbors, we ultimately end up prescribing sulfonylurea, and most of us ultimately end up prescribing thiazolidinediones. Dr. Lakshman told me that I will have a lot of points. I actually just have two. And I'm just going to make those 2 points, and then we'll see the rebuttal from Dr. Anantharaman. So this is what my topic says, that irrespective of what cardiovascular outcome trials say, I am going to prescribe my patients sulfonylurea and thiazolidinediones. In fact, we have known at the turn of the century, in 2002, Nathan's group had said that these are the groups and these are the things that you can hope to achieve with these molecules. And you can see that the sulfonylureas, metformin, and thiazolidinediones were really, really up there. I'm not going to spend a lot of time on any of the slides. You are all familiar with this. Based on these class effects, 2006 saw the first treatment algorithm by the ADA EAST, the first time that people on either sides of the Atlantic agreed to each other. And they said that once your patients do not respond to metformin, these are the 5 questions that you need to ask yourself when you're prescribing the next molecule. The first question you notice is efficacy, because if efficacy had not been the issue, if hypoglycemia, weight gain, cardiovascular disease, and specific side effects had been the issue, then Digene gel would have been a great antidiabetic, because it doesn't produce hypoglycemia, doesn't produce weight gain, has no cardiovascular risks that we know of, no side effects, but it also is not efficacious. And so you will not prescribe Digene to your diabetic patients to reduce their blood sugars. What you will prescribe is sulfonylureas. You can expect an A1C reduction of up to 2, and thiazolidinediones, you can expect a A1C reduction of 1.4. This paper was published in 2009. By that time, the DPP-4 inhibitors were already on the scene. You see what the expected A1C reduction with DPP-4 inhibitors was? 0.5 to 0.8. Remember that in 2006, the alpha glucosidase inhibitors were already on the scene, and they were not even put on the algorithm, saying that they are hardly effective and we are not going to talk about this anymore. People still don't talk about the alpha glucosidase inhibitors on these algorithms because they are not very efficacious. So what are we going to say about the DPP-4 inhibitors, right? This is what the first algorithm had said about sulfonylureas. 1.5, inexpensive, weight gain, hypoglycemia. They were economical, they were effective, and they had years and years, decades and decades of experience. 3 generations of diabetics had already experienced advantage with sulfonylureas. The problems were hypoglycemia and weight gain, and we are going to talk about that subsequently. What about the thiazolidinediones? 0.5 to 1.4, as we discussed. Lots of positives actually before Dr. Nissen actually spoiled the thiazolidinedione party. It was actually supposed to be cardioprotective because of all these soft things that it did. I am not going to talk about anything in detail. I'll be happy to have that in the discussion later on. The problems that thiazolidinediones had was not hypoglycemia, which it did not produce. It actually produced weight gain and edema, which most people thought was more peripheral edema than congestive heart failure. So, are we justified in only talking about glycemic control? Ultimately, remember, although in recent years we are not talking about glycemic control too much, it is the primary thing that you need to do for your diabetics. They have come to you with a high blood sugar and you need to treat that. And is it desirable in the long run? The UKPDS has told us that it is. There is a 14% reduction of myocardial infarction with a 1% reduction in HbA1c. And you thought that glycemic control was not very important for the heart. Even the much maligned advanced study had shown that there is indeed a slight favoring of all the endpoints if you have a more intensive control. And UKPDS has told us that not only are you making a difference now, you're also going to make a difference subsequently when the patient is not being aggressively controlled anymore, because the body is going to remember this good control initially. And so you need more powerful molecules. The UKPDS have told us that it really did not matter what you used for this intensive control. In fact, they found the same kind of legacy effect, good legacy effect with the sulfonylurea group. Are put to sleep, so jao abhi glibenclamide aa jayega, kind of scary stories. That glibenclamide produced the kind of legacy effect that we have seen after UKPD. If you also long-term efficacy, remember that there was this concept of flogging a dead horse, saying that the pancreas is already dead, and if you give sulfonylureas, you're actually flogging a dead horse. Turns out it is not true, because all the data with sulfonylureas versus the newer molecules, which are supposed to be better in the long run, have shown that up to 1, 2, or 4 years data, the difference between the lines with sulfonylurea and sitagliptin in this case, and sulfonylurea and empagliflozin in this case, does not seem to be any difference in the long run. So you are producing a better control in the short run. You can see these graphs. The gray graph is glimepiride. The first 4 to 8 weeks, I'm sure the patients who were on glimepiride loved their doctors more because the sugar control came down immediately to 7. Empagliflozin took its time. Once it gets into motion, once it's sort of established its effect, you can see that empagliflozin is a great molecule in the long run. This is not about maligning the newer molecules. Just concentrate on the glimepiride line. The overall control in the long run actually appears to be pretty good. And if you thought that stimulating the pancreatic beta cells is going to cause more harm than good in the long run, think again, because the data shows, again, this is from UKPDS, that the slope of loss of efficacy of the sulfonylureas is no different in sulfonylureas as compared to other molecules as metformin. You do not expect the metformin to cause beta cell failure. So what you are seeing with sulfonylureas also is the body's innate tendency of losing beta cells in the long run. The sulfonylureas apparently are not causing that. And so from 2006 to 2016, the ADA guidelines, I'm sorry, I kept telling you that I will not talk about CVOT trials, but since everyone else will talk about it, I'll have to justify my stand by mentioning them in passing. So till 2016, the guidelines were no different. The only thing that was different was in 2006, after metformin failure at that level, you had 3 boxes. Subsequently, there were 6. But the 5 questions that you need to ask remain the same: efficacy, hypoglycemia, weight gain, side effects, and cost. Efficacy, as you can see, was high for only 3 boxes: thiazolidinediones, sulfonylureas, and insulin. All 3 molecules incidentally cause weight gain, and all 3 molecules are up there in terms of efficacy. So till 2016, this guideline was about glycemic control. Your patient has come to you, you need to control their blood sugars. What are you going to give them? These 3 were the number 1 go-to molecules at that point of time. Sure, we're worried about weight gain. We know that if you actually produce more insulin in the body is going to gain some weight. Insulin, remember, is a lipogenic hormone, and insulin, as you can see, if you give it that red line there, as long as you keep giving insulin, the weight gain will continue. Glibenclamide, on the other hand, plateaus after some time, and so you will have some weight gain. You will have to tell your patient about that, but it does not seem to be a very bad thing in the long run. How about hypoglycemia? Sure, they cause hypoglycemia. Pioglitazone does not. Sulfonylureas do. So sitagliptin, you tell your patient that I'm going to give you a tablet which costs 8 times as much, and it does not produce hypoglycemia. Think again. This is from the sitagliptin data. Sulfonylurea plus metformin on the right side of your screen versus sitagliptin plus metformin. 5% of the patients who were on sitagliptin on metformin did have hypoglycemia. So if you give this fancy, expensive molecule to 20 patients, one of them is going to come back to you with hypoglycemia. What are you going to tell them? When mankind discovered the knife, remember, it also devised a handle. So you should not be worried about the sharpness of the knife. We have a handle, right? So what are the side effects of sulfonylurea that you're worried about? Hypoglycemia and weight gain? These are not side effects. This is what the tablet does. These, ladies and gentlemen, are side effects. And these are there in none of the sulfonylureas that you use and in practically all the newer molecules that you have. If you're worried about other side effects, then shouldn't that be a greater concern for you and not a hypoglycemia, which this molecule should be doing in the first place? And we are so obsessed with heart disease. Remember that the only study which showed some bad effect on the heart by sulfonylurea was UGDP study. That was in 1960. Most of you, I'm sure most of you out there are younger than me. You haven't even seen a tolbutamide tablet, let alone use it. I believe it was called Rastinan, and we old-timers have seen it. But you guys cannot even prescribe tolbutamide. What are you worried about? It's fine. And so in 2019, what do you think changed? Till 2016, it was a completely different looking algorithm. Now suddenly it has changed. And there you are. Thiazolidinediones right there. You can't even see it. Sulfonylurea right there. Small letters. Read the fine print. That is where they have been relegated to. I wonder why. This is one reason, of course. Rosiglitazone actually spoiled the entire thing. Although rosiglitazone is a very good example that even if you have law behind you, you still cannot get justice all the time, because rosiglitazone actually passed the record trial. There you are. The hazards ratio is 0.99, no different than a a DPP-4 inhibitor, right? And yet rosiglitazone was withdrawn from most of the countries. The earlier cardiovascular outcome trials actually showed neutrality. They actually started talking about, after the DPP-4 inhibitor trials showed neutrality, they said that already these patients are so well protected by statins and antiplatelet drugs, you really cannot expect anything better. And this was the study which actually compared a sulfonylurea and a DPP-4 inhibitor. You know this study. I am not going to spend too much time. This is what the headlines talked about after the study. It said this is a verdict for glimepiride. Yes, it is. It is effective and it is not guilty of cardiovascular harm, in spite of the fact that you know that the glimepiride up titration was huge. Normal people with HbA1c around 7 was up titrated forcefully to 4 milligrams per day. How many 4 milligram per day glimepiride prescriptions do you have? And yet there was no problems with the heart. The proactive, very old study, I am not going to spend too much time here, but this is what the proactive study showed, you know. The primary composite endpoint, hazards ratio of 0.9, statistically not significant. Secondary, time to death, myocardial infarction, hazard ratio was 0.84 with pioglitazone and statistically significant protection. You don't even talk about protection about this. This meta-analysis was 2 years after the Nissen meta-analysis for rosiglitazone. It showed that pioglitazone alone and in combination had a hazard ratio of 0.69, which was statistically significant. It was a cardioprotective molecule. I am not going to talk about cardiovascular outcome trials. I promised you in the beginning, I am not defending these molecules based on what the cardiovascular outcome trials have shown. But I leave you with this question. This is my last slide. You are sitting in a clinic. A 43-year-old patient who has first been diagnosed with diabetes has come to you with blood sugars of 243 and nearly 300. His HbA1c is 8.9. You say that this is fairly high, you require insulin. He's not very keen on insulin. I have not yet met a patient who comes to your room and said, please give me insulin. I love taking shots. So he's not very keen on insulin. What will you give? How many of you will not give this patient a sulfonylurea? I think that's my last question, and I'll rest my case. Remember that knowledge has its dangers, yes, but that response cannot be a retreat from knowledge. And this was written by Isaac Asimov. I'm sure all of you are big Asimov fans. He's not a doctor, but he hit the nail on the head, I thought. Lastly, if you're worried about the weight gain, you can tell the patient to take the dog out for a walk. The dog might become healthier, leaner. The patient might not. But would you say that that's the sulfonylurea's fault? I think I will stop here. Thank you. I will stop sharing. And if you have any rebuttals or discussions, we can have it subsequently. Thank you.
I think can come back, Dr. later, the second lecture.
Yeah, I have great pleasure in introducing Dr. Anantharaman, as Dr. Prasoon has clearly shown his overview on SU and glitazones and its benefits. And as Dr. Anantharaman will give his views on evidence based on hard endpoints. Is there any role or no role of SU and glitazones? Dr. Anantharaman.
I thank Dr. Prasoon for joining us today and for his spirited case he has made for SUs and pioglitazone. I'll start by saying that, quote unquote evidence based on hard endpoints, and I do not see any role for SU and TZDs in type 2 diabetes mellitus. What Dr. Prasoon was telling so far might have applied to what was in the past, but now we are in 2021, and in the future, I really do not see much of a role for SU and TZDs or expansion of its use at least. So let me start with bringing to notice what is evidence-based medicine. So it's basically we incorporate the best research evidence and along with that clinical expertise and patient values. So these are three important things when you talk about vildagliptin, of course, is available as generic. So affordability has become less of an issue, and then we have a lot of new evidence. That's one of the reasons why the evidence-based practice recommendations from ADA have changed. So Dr. Prasoon was saying that up to 2016, we were not emphasizing SGLT2 inhibitor so much, and now why we are this thing. So I'll show you the evidence for that. And also, our clinical expertise matters. Just because you have a tomato, you don't put it in a fruit salad. If you're a cook, you should know that you should not put it into a fruit salad. So everyone talks about these aspects. So I'm going to focus only on the central theme of today, which is what is the evidence out there for alternative agents. So how do we understand use of various agents in any disease for that matter, not only for diabetes. So we want to look at what are the benefits associated with sulfonylurea and pioglitazone use. I think Dr. Prasoon has spoken about it. And then we need to understand what are the alternatives out there, what are the other molecules out there which are available. What are the risks associated with the use of alternative agent vis-a-vis sulfonylurea and pioglitazone? And also, we want to know this in the natural course. I mean, what happens in the course of the disease, natural course of disease. So, my opponent was actually commenting on the conventional view. He was harping on better lowering of A1C, and he was talking about glycemic durability alone. The modern view is that we want to not only the blood glucose to be controlled, we want an agent which can probably decrease mortality, which is very hard to demonstrate. So, and decrease the morbidity related to microvascular complication, improve the quality of life of the patient. So one of the important aspects of quality of life is not having to have hypoglycemia or weight gain. So, and we also want to reduce CVD and CVD mortality, because these are the #1 cause of mortality in our patients with diabetes. And also, could it decrease cancer mortality? That's one of the additional things that we need to look at. So when we are faced with giving oral therapies to patients, so the metformin, of course, is considered universally applicable for all our diabetes patients. Now we're talking about only SGLT2 inhibitors and DPP4 inhibitors, and we want to focus on long-term outcomes while comparing these therapies. So, this is a recent meta-analysis which has appeared in December 2020. So this is a meta-analysis of all the trials, recent trials, including the ertugliflozin trial, which was not, did not show superiority for this thing. So on the right-hand side, you can see the reduction in all-cause mortality. So all-cause mortality is death due to any cause. We are not differentiating it as cardiovascular mortality or cancer mortality. So in long-term trials, so there was a 10% reduction in mortality. And when you look at the overall reduction in mortality, it is 0.86%. This applied across the board, EMPA, CANA, and DAPA. And even if you see ER2's value was also trending towards the left side. There was a huge amount of, lack of heterogeneity. I mean, we look at, whenever we do a meta-analysis, we want to see whether the effects with multiple molecules is going towards the same side. So here what you're seeing is that all of it is to the left, and it's got a low heterogeneity, and we expect at least 10%, at times even a 20%, somewhere 10 to 20% reduction in mortality. Total mortality is what you achieve with SGLT2 inhibitor. Of course, it included a lot of trials which were in CKD, HF, etc. But then it did include large trials which were done in patients who are day-to-day type 2 diabetes patients, like CANVAS and your Declartimi, and even the EMPA-REG was done in many patients, though they were high risk in immediate post-event period. So, and also another important thing to note is that one of the biggest advantages of SGLT2 inhibitors is that it keeps your high-risk patients out of hospitals. So with the earlier agents, with pioglitazone, I'll show some of the studies with pioglitazone which actually increased hospitalization. So the whole purpose of giving medication to our patients is that they stay out of hospital and we are able to manage their diabetes very well. So across the board, the SGLT2 inhibitors are actually reducing heart failure hospitalization by almost 50%, which is a fantastic number. So, and again, CV death is definitely prevented in patients who have prior ASCVD. In those without ASCVD, there is not such clear evidence. But when it comes to preventing cardiovascular death, so SGLT2 inhibitors, especially empagliflozin, canagliflozin, and dapagliflozin, are right up there. When you do a meta-analysis of all these trials together, you find that as a class, they are very effective. Of course, VERTIS-CV was the only negative trial. So apart from that, all the others are positive. And another important role of SGLT2 inhibitor is that they reduce the composite of kidney outcomes, one of which is actually dialysis. So one of the important things that we don't want the patients with diabetes to experience is actually go on dialysis. So SGLT2 inhibitors reduce the progression of kidney failure. So this again is a huge plus point for SGLT2 inhibitors. So this is basically analysis from the empagliflozin trial, EMPA-REG outcome trial, which shows that empagliflozin, this is not a significant trend, statistically significant, but then it did show that there is a tendency towards improvement in clinically important ocular endpoints. So it does prevent progression of retinopathy. So this kind of data is not there with SU and pioglitazone. So when you look at DPP-4 inhibitors, as the previous speaker has alluded to, they are neutral as far as mortality is concerned. All-cause mortality, CV death, and stroke and heart failure hospitalization is concerned. So why to use a CV neutral molecule, that is a DPP-4 inhibitor? So two reasons. Number one reason is that 80% reduction in symptomatic hypoglycemia. This is important from the patient point of view. We do not want our patients to experience hypoglycemia. See, many of our patients may be blue collar workers. They may be Uber drivers, or they may be doing even a lowly paid job also. But even those jobs require that they do not take food intake, every 8 hours or so. Every 4 hours or so, they are not able to go out and eat actually. So DPP-4 inhibitor therapy, even in those individuals, helps a great deal with the availability of vildagliptin as generic. So it is within the reach of almost all our patients to take a DPP-4 inhibitor. Cost is no longer a constraint, and it has got a placebo-like adverse event effect profile. You need to actually search to find the adverse effect. So there's a big list of adverse effects that Dr. Prasandev had shown, but most of these adverse effects are actually very rare. They are probably less than 1 in 1,000. Absolute incidence is very, very rare. Pancreatitis is very rare with DPP-4 inhibitor. Even if there is a small excess, it's a very rare event. So that, in that background, is what the American Diabetes Association is saying, that if you have ASCVD or if you have CKD, it's a compelling indication to start SGLT2 inhibitor for our patients. If they can afford GLP-1 analogs, that's the best. Okay, so if there is a compelling need to minimize hypoglycemia, so we should use DPP-4 or SGLT2 inhibitor. I would not think of many situations where there is no need to minimize hypoglycemia, or in almost all situations, we want our patients not to get hypoglycemic. All right. So thiazolidinediones also do not cause hypoglycemia, but then there are several problems with thiazolidinediones. I'm going to show you in the next few slides. So where cost is a major issue, I think the right-hand side is where, in our situation has changed actually. There has been a sea change with DAPA becoming generic, with the availability of Remo. So we have a huge amount of availability of SGLT2 inhibitor and DPP-4 inhibitors, where cost is not a major issue in our setting anymore. So when you look at pioglitazone problems, weight loss is not there at all. It does cause weight gain, and sulfonylurea also causes weight gain. So we cannot simplistically say that, sulfonylurea, just ask the patient to exercise and diet. I mean, doesn't really work, because weight gain is a complex phenomenon, and defensive eating is really a thing. The patient has to eat in order to prevent hypoglycemia. So the lack of hypoglycemia is because the patient is eating and then he's gaining weight. So in the BRAN analysis, so let's look at the risks associated with pioglitazone therapy and sulfonylurea therapy. So pioglitazone has got a huge litany of problems. So it can cause edema, it can cause heart failure, anemia, fractures, and weight gain. Let's look at the evidence. So this is edema. So almost across all trials, these are trials done across a lot of patients. Like, for example, this IRIS trial is done in post-stroke patients who are non-diabetic actually. So edema was present in a huge number of patients. Around 10 to 15% of your patients across the board will have edema if you start them on pioglitazone. This is something that patients do not appreciate. They feel that if they have edema, they have some problem. Heart failure, patients, serious heart failure does develop in patients. I've got another slide for that. I'll just show you the next slide, which shows how severe the heart failure problem is. So in the proactive trial, you see in the intervention arm, around 14.6% had exacerbation of heart failure, and about 6% of patients were indeed admitted to the hospital with heart failure. So we cannot assume that proactive is actually a positive study for pioglitazone. I mean, even when the results came out, they did not play it up a lot, because the heart failure hospitalization was massive with when you use pioglitazone in post CV outcome patients. I mean, you really cannot use it in that setting. So, and almost there is a doubling of risk of heart failure, whether it is post-MI patient, high-risk patients, or newly diagnosed type 2 diabetes patients. So even in ADOPT trial, where it was basically done for glycemic durability, you see there is a doubling of heart failure, 0.3% in the glyburide and metformin arm, and 0.6% in the control arm. It doubles the occurrence of heart failure. Anemia. This is a very interesting study. It's a randomized trial where patients who are on pioglitazone, where they stopped pioglitazone and shifted to dapagliflozin. So this is exactly what we want you to understand. So what happens when you do that? So when you stop DAPA and then put them on, you stop pio and put them on DAPA, so the patient loses around 4 to 5 kilos weight, and then the hemoglobin also increases. You can see that it's gone up from 14.1 to 14.9 grams of hemoglobin. Whereas if you continued pioglitazone, the hemoglobin stays the same and the weight also stays the same. So, this illustrates to you the opposite effects of SGLT2 inhibitor and pioglitazone on various markers that are very required. Of course, fractures are a huge problem with glitazones. In the ADOPT trial using rosiglitazone, the prevalence of fracture was double that seen in metformin and glyburide. And in the IRIS trial, the relative risk of fractures increased by 47 to 60% with pioglitazone. But the important thing to note, it is mostly for ladies, basically. So the men were not affected in both in any of these analyses, and even in the analysis done, it is not. I don't want to discredit unfairly pioglitazone, but I want to say that definitely there is an increase in risk of fractures with pioglitazone. The older sulfonylureas were associated with excess mortality. Definitely, glycoside is probably not associated with excess mortality. But then it can definitely induce hypoglycemia at a much higher rate than DPP4 inhibitors and SGLT2 inhibitors. Whether to use it or not is up to you. But then I'll end with this piece of gossip from Twitter. So he's a senior KOL from the US who has tweeted that sulfonylureas especially are cheap and bad for your grandmother. And I will not talk about insulin because that's not the thing. And then, it is a more relevant, more than glucose, it was the hypoglycemia which was a predictor of death. So I would end by saying that pioglitazone and sulfonylurea is not good for your friendly dadima, at least. So, if you are intending to start pioglitazone and sulfonylurea for your grandmother, please do not stop right now.
Good afternoon, everyone. I think we have come to a rebuttal part of this debate. I would like to request Dr. Prasundev to give his comments, final comments.
All right. You see, there are three kinds of lies: damned lies, and statistics. Statistics, if you have a good statistician in your payroll, you can actually make the numbers tell you whatever you want them to. So when you have these meta-analyses and looking back kind of studies, I do not think that is going to give us any added information about how to proceed further. Now, the problem with the 2016 to 2018 change that we have had in the ADA algorithm is that it has moved from a glycemic control algorithm to a comorbidity control algorithm, which is fine. We did not have anything earlier, as Dr. Anantharaman has told us. We did not have anything. We did not talk about congestive heart failure because we had nothing to do about it, and now we do have something, and that's fine. But remember that all these advantages that you have with these molecules are with patients who already have some amount of that disease already on board. There is till date no data which suggests that someone who has nothing, absolutely a clean de novo diabetic, starting them on these newer molecules is going to give them any advantage in the long run. There is no data for. However, because of various reasons, and not all of those reasons are academic, I suspect, that the push for these molecules to be given to less and less sicker people is afoot, without any advantage, any data suggesting that this is going to help in the long run. A very good example is heart failure with preserved ejection fraction. The data from HFpEF is not in yet. We do not know what the data will show us in with SGLT2 inhibitors, but I suspect that it will not show a statistically significant prevention. It did not show statistical significance for the ARNI molecules, and yet ARNI was recommended for this group. So there is something seriously wrong here afoot. At this point of time, your patient primarily come to you for glycemic control. If you have a molecule which has not clearly shown to be deleterious, then you should be using that molecule. If the patient already has a congestive heart failure, sure, I agree with Dr. Aman. You give whatever is needed. You were giving other molecules also. The cardiologists were treating them. And now cardiologists are probably bigger prescribers of SGLT2 inhibitors than the diabetologists. And that's fine. That's how it should be. But if a person does not have this, is there any advantage for giving something other than a sulfonylurea or pioglitazone? I am not so sure. I mean, this is of course open to interpretation, and I'm sure the chairpersons will give their vote, and I suspect that the vote will be against me. But still, that is what I strongly feel.
Yeah. Dr. Anantharaman, can you give your final comments?
No, I don't have any comments to make. I mean, I'm sure, I said, it's just for the sake of debate. It's a friendly debate. I mean, I don't want, this is not a fight. Okay. So basically what I want to say, the hidden agenda behind what I want to say is that don't give pioglitazone and sulfonylurea to your grandma. That's all. At least when you reach my age, when you're 40 and your grandma is much older, 60 or 70, don't give sulfonylurea and pioglitazone to your grandmother, because it does increase fractures, it does increase heart failure. So, but even this is a important important conclusion, I would say. I mean, even if you have to come to a consensus from a debate, so this will be an important consensus, because the prevalence of diabetes increases with age, and many people become diabetic just because they are older. So the best choice of drug for them are going to be metformin, SGLT2 inhibitors, and DPP4 inhibitors. So, I mean, if you're able to avoid SUs in that age group, I'm very happy with that.
So you're agreeing, Anantharaman, with Dr. Prasoon, because our average age group of diabetes is between 40 to 60. So what
those who come to us, sir, those who come to us, I'm not sure that
because everybody has grandma.
So
grandmas who don't see regularly.
They will probably ask you on WhatsApp, and then you'll have to send a prescription. That's
for grandma, we'll take care of grandma, but in reality, what Prasoon was
problem is, in India, you can become a grandma at 50, because marrying young is not very uncommon. So what would you say to a 50-year-old grandma? Is that acceptable to her? So.
Anantharaman, can I make a comment?
Yes, sir.
Yeah, I think you are talking about heart failure. What about the DPP4s? In states, all the DPP4s comes under a black box warning. They should not be used. Concern of heart failure. It's not only for your allogliptin and the saxagliptin. It's also for all the DPP4s. Even your Vivaldal trial with the cheapest DPP available here, it shows LV end diastolic pressure greatly goes up. It has not shown any benefit in patients who had a heart failure with reduced ejection fraction. That's the problem. So it's not uniformly, however small risk of pancreatitis is quite high. It's quite severe. They get a severe pancreatitis. I've seen patients who have developed a severe pancreatitis. That concern is not there with the. I think I still vote for the common people. The glycoside modified release preparations are very, very safe. If you really titrate, up-titrate, the hypoglycemia and weight gain part of is much, much less. What about the? Why do you want to discard the pioglitazone? No, drug which is the one effective against the NASH, the NAFLD. I think nobody has mentioned that. It's the only drug available along with vitamin E. I think read a recent article 2019 by how beautifully pioglitazone in a modified dose can be tried, because all the patients in the trial with your proactive or patients who had suffered an event They all post-MI patients. They are put on to proactive study. They completed 4.5 years. Stroke benefit was there. Patient had improved. And I also wanted to know, steno trial, they never used SGLT or DPP4s. They used only a sulfonylurea metformin. Still, the steno 4, the comprehensive health care of everything, statins, metformin, aspirin, antiplatelet drugs, the outcome was excellent. I think the way what we use, I think we are over biased by the outcome trials. And as rightly President said, it's only for the compromised group, not as a primary prevention group. We can really start the basic molecules. There was a contraindication starting in SGLT2 with the pioglitazone. It's going to be helpful. It's going to nullify the effects. Day, I am for you.
Yeah, that was a pleasant surprise. Thank you, sir.
We are all.
And you raised this at the Carolina trial, no? It was shown glimepiride is equal to the softest linagliptin.
Yeah.
No deviation in the upscale or downscale.
Given that it produced a lot of hypoglycemia, the uptitration was scary. People who had an A1C of 7 and 7.1 were uptitrated rapidly from 0.5 to 4 milligrams per day. You would probably not do it in your practice.
I think in India we maximum use 2 milligrams. We don't use 4 mg.
So in spite of that, there was no increase in the cardiovascular adverse outcomes. And that actually should tell us something.
What I would say, the pioglitazone, why it has been pushed down in India is because it scares the bladder carcinoma signal came, and that's the time it has been pushed down by the pharma companies. I think
and
not
for it was banned for some
it was
time.
Banned for the bladder carcinoma. So
I thought it was more of market driven thing.
That's I think.
We'll have to conduct this debate with some demeanor. So the nation wants to know if Dr. Prasun, if the patient is you or your mother and HbA1c is 7.5%, will you give sulfonylureas or will you give DPP4 inhibitors and metformin? Nation wants to know.
So we have some specific numbers there.
7.5%, fasting 122. Postprandial 250. I'm purposely speaking loudly, okay? Please don't be sure. Nation wants to know. Nation wants to know that. 7.5%.
This.
Huh? Yeah. Will you give some? Like patient wants. What will you do?
You all know the DPP4s are the elderly people's molecules. Doesn't cause hypoglycemia, weight gain, but they are so soft. We can't reduce the A1C from 8.5, 8.9 cannot be brought down by your DPP4s. I would always say that the glycoside modified release is as economical, plus it's also very effective. You have only uptitrate the dose. You can definitely use it in your grandma, glycoside, very, very soft tablet for even elderly population.
Okay. Actually, I wanted to ask two different questions to Dr. Prasun and Anantharaman, where the scenario changes, where we are treating Prasundev or his parents versus Anantharaman's parents-in-law. So suppose your mother-in-law is being treated Anantharaman. Would you like to still give DP4 or would you like to give sulfonylureas?
Only DPP4 for my mother-in-law. We treat everybody equally. Yeah.
That was a very diplomatic answer.
It's economically viable, no? Sound.
I know. This is joking. So I think the conclusion is that all molecules are absolutely safe as far as glycemic lowering ability is concerned, and you should individualize the patient. You can't say that these medicines are completely gone. In our common day-to-day practice, I'm sure Dr. Anantharaman is also writing a lot of pioglitazone and gliclazide or even glimepiride. And also Dr. Prasundev is considering in some patients not to give sulfonylureas.
Yeah.
So
my only thing is I like personally gliclazide modified release a lot, but then the actual fact is that many of the gliclazide modified release actually more costly than DPP4 and SGLT2 inhibitors now.
Yeah.
That is the thing. It is almost 10, 12 rupees. Good.
The cost question, as you say, is standing on its head now. The actually cheaper. And that's sulfonylurea. So that is out of the window.
Gliclazide being a niche molecule, I think a lot of companies are not coming out with newer drugs, and it's all glimepiride only. It's awash with glimepiride actually. And glycoside, there are very few companies which are marketing it, and they don't want to cut the price actually. I mean, it's quite expensive.
But then we were not discussing the cost.
Okay.
So, Raman, summing up.
Yeah, I think both the speakers have done exceedingly well in arguing. I think the CV safety data of sulfonylureas and TZDs, although it is not that robust compared to the recent drugs, but we definitely agree that they continue to be used in our clinical practice because of other advantages. They are efficacious and economical, widely available. And only thing we should remember is we should avoid in selective patients where the associated comorbidities may cause problem with their uses. I think that should be the key take-home message from this debate. So I think, if there is no other comment from my co-chairperson, we can conclude.
Thank you. I think I must congratulate both Anandaraman as well as President, make it very interesting. And I think rightly the conclusion is you have to use depending on your patient. And I always say ABCD, A1C, BMI, comorbid conditions, and the duration of diabetes and the economy of the patient. Finally, that's the one which comes in play. So all those things has to be put into your mind before you write a prescription for your patient. It's not strictly that we are there to only DPP4s and SGLT inhibitors. Still, I think we have to use the sulfonylureas now with us more than 40, 50 years. I think we can't go away with that molecule.
Yeah,
thank you for all the organizers.
Yeah, both speakers spoke very well, and I think an excellent presentation. I think patient-centric approach and individualized therapy is the key. Thank you, faculty and chairpersons. Thank you, Dr. Santosh, for the opportunity.
Thanks.
Thank you. Have a great day.
Yeah.
Thank you.
Thank you.
Yeah.
Thanks for having us, Magna. Thank you.
Thank you.
Sudhakar is going to give us the vote.
Yes. Before winding up the session, I hope all of you enjoyed this academic feast, lucid talks, nice debate with perfect management of time. And I would like to thank all the chairpersons for sparing your Sunday and active participation and nice interaction. And I would like to thank all the speakers for their lucid talks. And special thanks to delegates, organizers, and technical team. Last but not least, sponsors of this program, this wonderful academic event. And once again, thank you one and all for this grand success of virtual event. And hope to see you all once again on next Sunday for second half of the Magna Endo update. Take care and stay safe.
Thank you.
Thank you.
Okay, thank you. Bye.